Dr. Revati, your audio doesn't seem to be working.
We are live now, ma'am.
Yes, yes, yes.
Yes, now I think you are on.
Yes, Sakiti. Have you started recording?
Sakiti, we can start.
Okay. Good evening, esteemed faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect, welcoming you all for today's webinar on fibroid, organized by Tnfog. It's my pleasure to invite the MOC of today's webinar, Dr. T. Radhika Gauri ma'am. Ma'am is the specialist consultant in OBG and clinical lead at ESIC Hospital, Tirunelveli. I welcome you, ma'am, and I hand over the session to you.
Thank you, Saiti, for your kind words. Good evening, all esteemed faculties and delegates. Good evening, Sampath ma'am and the organizers. Ma'am, can you please take over for introducing Ramani ma'am? Thank you, ma'am.
Good evening to all, and I welcome Dr. Farul sir, Dr. Ramani madam, Dr. Revati madam, and all the delegates and the faculties, Dr. Karthika. See, this marathon CME is the CME conducted by the TNFOG on every month, second Friday. Why we call it as marathon means we have 3 sessions. One session is Yuva, and second is update, third is panel. After each session, we will ask some questions to encourage the delegates. So whoever is answering first will be given some gift, like whatever it is needed, the BPR pattern, glucometer, like that. And the marathon, the Yuva session is 2 Yuva from any in Tamil Nadu, from Chennai, Madurai, from any places. We have almost 20 societies. This Yuvas will give the talk, and we have 2 permanent judges. This time we have Dr. Karthika and Dr. Revati Janakiraman as the judges. They will present for 12 minutes and they will ask for 3 minutes. And whoever is the best orator will be awarded in the annual conference. So that's the reason we have called it as the Marathon CME. And I welcome you all. Sakiti, now you can play the Samhita verse and pray.
Okay, ma'am.
So I invite Dr. Ramani ma'am to give the welcome address. Dr. Ramani ma'am is our current president TNFOG. She's been the national vice president FOGSI 2020 and ICOG governing council member between 2008.
Radhika, I think just cut short that as just a president of TNFOG.
Okay.
Good evening, one and all. As a president of the Tamil Nadu Federation of Obstetric and Gynecology, I am very happy to invite all of you for the second Marathon CME. And today we have with us the chief guest, Dr. Parul Kotadwala, and guest of honor, Dr. Neeraja Butla. And as Sampath had already mentioned, we have a Yuva session that is followed by a scientific session plus a panel discussion. Today's the topic is fibroid uterus. So the fibroids are the very commonest tumors what we see, benign tumors what we see, and as age advances, it goes even up to 40 to 50% of the perimenopausal women are likely to have fibroids. So we need to understand what is the probable cause and how it presents, what will be the symptoms, and then how it should be diagnosed and what should be the proper management, whether the patient needs a medical management or surgical management, or what is it impact upon the fertility and impact upon during pregnancy and during the perimenopausal perimenopausal period. Now, Sahiti, can you share Dr. Parul sir's CV? So today I have great pleasure in welcoming our senior Dr. Parul Kotadwala, who is currently the chairman of ICOG, and he is a leading endoscopic surgeon and consultant gynecologist at Ahmedabad Kotadwala Women's Clinic and senior consultant at Zydus Hospital, Ahmedabad. He has been the past vice president of ISOPARP 2021 and 22 and chairman education committee of Tnfog, India coordinator of NESA, that is New European Surgical Academy, India coordinator of International Addition Society, vice president Foxy in the year 2006, president SOGOG, State Organization of OBGYN of Gujarat in 2009, and president AOGS Ahmedabad Society in the year 2007 to 2008, and chairperson of Scientific Committee of AICOG in 2017. He is a very soft-spoken person, and added to that, we could have all seen his efficiency in conducting the LSCS workshop. That was the first time which I came in contact with Dr. Parul, and I was really happy to see his surgical skill. And today also, I was just telling that every gynecologist should understand how to do a proper LSCS. Because yesterday I came across a very rare case of uterocutaneous fistula that is only iatrogenic. Probably the first case was done by the first section was done in a medical college where nothing was given, and the second surgeon had opened and full of addition. So she has done a inverted T-shaped incision, and within 6 months the patient has developed uterocutaneous fistula. So these are all iatrogenic complications, and I think Dr. Parul has done a very good job by educating what are the most important points that we have to take up when we do a most commonest surgery, that is LSCS. I welcome Dr. Parul, and I need your blessings for today's program, sir, as a chief guest. Thank you.
Well, thank you
Welcome,
very
Dr.
much.
Parul. Welcome
Hello.
you to Madurai also soon.
Sure. We did one cesarean workshop in Madurai as well.
Trichy also
Sure,
you
sure.
Theni, Kanyakumari, Trichy, Chennai. So I think we have gone to all places in Tamil Nadu for cesarean workshop. Anyway, today is the focus on fibroid.
Yes.
Thank you very much for kind words about me. Fibroid, I have often said that whoever finds a cure of fibroid will become next Bill Gates, because such is the potential to handle this pathology, and we do not have any answer. We have been trying to find a reason, because every patient, when we tell them you have a fibroid, it is not a cancer mostly, but it is a tumor. And then they always ask us, why does it happen? We have no answer. Even if we operate for a myomectomy, remove it, they would say, would it happen again? We have to tell them it can. So then they start thinking whether one should undergo a surgery or not. So I'm sure today your marathon will cover all these aspects. I really like the word marathon. But then you are very fast people. So in 3 hours, you will finish the marathon. Okay, I wish you all the best for the webinar. Please go ahead with it. I believe my colleague is not here, the Vice President of Fox.
No, she's joining. She just called me. She's joining in a minute. She's, I think
Okay.
she's
So please
joining.
get on with it. Thank you.
Thank you so much.
Okay, thank you, sir. Thank you.
Ma'am, shall we wait for?
Yeah, so
Session.
meanwhile, I'll let you know that next, yeah, Dr. Nirja has joined. Yeah, welcome, Dr. Nirja. Welcome. Sagiti, you can show.
Hello.
Yeah, good evening, Nirja.
Good evening. Good evening.
I have great pleasure in welcoming Dr. Nirja Bhatla, Professor and Head of the Department of OBGYN, AIMS, New Delhi. She is currently the Vice President of Foxy, Head and Gynec Oncology, National Cancer Institute at Jajir, and then first women doctor from India to grace as chairperson of FIGO Gynec Oncology Committee. That's wonderful. And led the revision of FIGO staging of cervical cancer. The number of advisory groups on issues related to women's cancer and maternal health and path-breaking researcher with more than 500 publications, developed several biomedical devices to promote training of health workers, screening, treatment of cervical cancer in remote areas, working to bring low-cost Indian HPV vaccine to reduce the cost of HPV vaccine for Indian girls and to develop low-cost indigenous HPV tests to promote screening. Screened and treated more than 50,000 women and organized events, camps, and activities to enhance awareness and participation, conducted health awareness and cancer reduction camps for underprivileged sections of the society. Dr. Nirja, I think with your good work towards this cancer prevention and cancer early diagnosis, I think and with the vaccines, I think we will get a cancer-free India even much before the stipulated time by the WHO. And we're greatly honored to have you as a guest of honor today for this marathon CME. Welcome, Dr. Nirja.
Thank you so much. Thank you so much, Dr. Ramani, and thank you, Dr. Sampath, for this kind invitation to be here today. And my greetings to Dr. Parul and to all the dignitaries over here. I just got out from the AOGD, executive, the first meeting of AOGD for the Delhi Society under Dr. Ashok Kumar. So it's very nice that I have Dr. Parul Kottawala now as the chief guest here. And thank you very much for your kind words of introduction. And my congratulations and compliments for this marathon CME concept which you have started. It is indeed a very unique one. But the TN societies are always very much in advance of everybody else. So I'm sure many others will follow the same example now. And this topic which you have chosen also of fibroid is a universal one and so much problematic for the patient. So I think this is a great program that you have made. And you have the wonderful speakers over here with Dr. Pratibha, Dr. Swati, this concept of the Yuva session that you have, and then very eminent after that, Dr. Chitra, and wonderful panelists that you have for your panel discussion on the case scenario. So I'm sure this is going to be a great session, and this is something which is so much bothering the people that you will make a lot of difference. So thank you for inviting me for your webinar today, and congratulations, and wish you all the very best.
Thank you, Dr. Nirja. Thank you so much. And also on behalf of TNFOG, I thank the chief guest as well as the guest of honor for having graced our marathon CME today. Then I also have the great privilege of welcoming all the judges for today's session, Dr. Kritika and Dr. Revati Janagiraman Madam, and the young Yuvas, as well as the speaker from our neighboring state, Dr. Chitra from Pondicherry, and all the panelists who are going to be with me for this wonderful fibroid session. Thank you.
Thank you, Dr. Neeraja and Dr. Parul, sir. If time permits, you can be here in the program. Okay. Dr. Radhika, you can continue.
Okay, ma'am. So thank you, ma'am. Now we'll move on to the Yuva session. I invite Dr. Revati Janagiram, ma'am, who is a past president of TNFOG, and she has been the former director IOG Chennai and Vice President of Foxy South Zone 2016, President Tnfog 2023, Founder Secretary, Past President Madurai OG Society, and Founder President IMS Madurai Menopause Society. And she's been
Okay. We can proceed to this thing, no? Okay.
Okay, ma'am.
Thank
Okay.
you.
I invite Professor Dr. Kartika Prabhu, SRM Medical College Hospital Research Center, Koteri. She's done her MBBS from MMC and MD from JIPMER. And she's an undergraduate, postgraduate teacher. Her special interests are high risk pregnancy, gynae endoscopy, midlife health. And she has received many awards. Umarchi Dui Memorial Gold Medal and Asha Bakshi Award Annual Conference in AICC RCOG 2016. And she has also received a prize for paper presentation in UA Foxy South 2011 and DIPSI 2013. And also she has received the Dr. A.L. Mudalia Traveling Fellowship, and she has over 20 national international publications. Welcome, Revati ma'am and Kartika Prabhu ma'am, and to chair the session on pathogenesis and classification of fibroid and features of an investigation. Welcome, Dr. Pratibha.
Thank you, ma'am. Good evening, ma'am.
And Dr.
Yeah. Radhika, you will introduce the first speaker, Pratibha? Or shall I?
Ma'am,
I invite Dr. Pradeepa, Assistant Professor from Karur Government Medical College. She has published in journals and she has an award-winning presentation on topic role of PTMC in mitral stenosis during pregnancy. Her field of interest is laparoscopy and infertility. Over to you, Dr. Pradeepa.
Thank you, madam. Ma'am, shall I share my screen, madam?
Yes. Start.
Good evening, madam. Thanks for the opportunity. My topic is pathogenesis and classification of fibroid.
we have 12 minutes. Dr.
Pratibha, you will be having 12 minutes and the 3 minutes judges will ask you questions. Okay?
Okay, yes, ma'am.
Your time starts now.
No, pathogenesis and classification of fibroids. The hormonal and influence of hormone influence on fibroid development. Estrogen and progesterone plays a pivotal role in fibroid development. The elevated levels of these hormones which stimulate the fibroid growth. Despite similar hormone levels, fibroid within the same individual may exhibit varying growth rate. It is the growth of the fibroid depends on the intrinsic differences in the hormone responsiveness. Estrogen and progesterone can influence the mitotic rate of fibroid cells and potentially leading to the somatic mutation and increase their growth. Fibroids express higher levels of estrogen receptors compared to normal myometrium, indicating their sensitivity to hormonal stimulation. Uterine leiomyoma growth is closely linked to estrogen and their receptors. MicroRNA and protein expression levels of estrogen receptor alpha and beta are higher in leiomyoma compared to normal myometrium. Estrogen may exert growth stimulatory effects on leiomyomas via cytokines, growth factors, and apoptotic factors. Estrogen can maintain progesterone receptor levels, thereby promoting the leiomyoma growth. Progesterone interacts with its receptors, progesterone receptor A and beta, which is playing the key role in myometrial and leiomyoma biology. It also interacts with the growth factors, upregulating the expression of EGF and TGF beta 3. Genetic and racial influences. 40% of uterine fibroids displays the chromosomal abnormalities. That is, it is translocation between the 6 and 10, 12 and 14, and trisomy 12. Deletion of chromosome 3 and 7. HMG-A2 gene involvement which is commonly found in leiomyoma cells. The prevalence is more among Black women, and it depends on the genetic factors and it is hormonal metabolism. The role of growth factors in the fibroid development. The fibroid pathology, cell proliferation, EGF and platelet-derived growth factor directly increase the mitotic activity of the myometrial cells. Angiogenesis, VEGF, which plays the main role in angiogenesis. Extracellular matrix remodeling is by TGF beta, which is hallmark in fibroid pathology. Growth factors in fibroid development: vascular endothelial growth factor, epidermal growth factor, heparin binding epidermal growth factor, transforming growth factor beta, platelet derived growth factor, insulin-like growth factor. The understanding pathogenesis, the following are the key points. One is mechanical properties. Leiomyoma, and the mechanical properties of leiomyoma are the key features of these tumors and may contribute to their growth. Transforming growth factor beta 3, which mediates the overexpression in overexpressed in leiomyomas than normal myometrium. ECM gene expression, the microRNA expression of multiple ECM genes in uterine leiomyomas is decreased when the TGF-beta pathway is downregulated. Indirectly means if TGF-beta pathway is upregulated, the mRNA expression is more, so more chance of getting fibroid. Pathological mechanism, the abnormal ECF expression, increased growth factors and cytokines, chemokines, which causes development and growth of uterine leiomyomas. Endometrial subendometrial myometrium unit disruption, which causes submucosal and intramural fibroids. The lifestyle and environmental risk factors are, which is higher chances of getting fibroid, higher intake of red meat, processed meat, and low consumptions of fruits and vegetables. The role of dietary fiber in reducing estrogen levels and its potential protective against fibroids. Sedentary lifestyle and lacks of exercise are main contribution towards fibroid. Regular physical activity, which lowers the risk of getting fibroid. So the key pathological mechanisms of hormonal influences, genetic factors, ECM dysregulation, angiogenesis, and inflammatory responses, that is chronic inflammation, which fuels a fibroid development by promoting cell proliferation. MicroRNA dysregulation, which aberrant microRNA expression disrupts the cellular process and contributes toward the fibroid growth. The knowledge about the pathological mechanism which helps us to treat fibroid even medically and prevent fibroid by lifestyle modification. So this is classification of fibroids. 0, it is Figo classification. 0 is intracavitary. It is submucosal. 1 is submucosal and less than 50% intramural. And 2 is more than or equal to 50% intramural. 3, 4, 5 are intramural. 3, 100% intramural with endometrial contact. 4, 100% intramural without endometrium or subserosal or serosa contact. 5 is more than or equal to 50% intramural and subserosal. And 6 is subserosal and less than 50% intramural. 7 is subserosal, which is purely pedungulated. And it is hybrid is 2 to 5, which from submucosal more than or equal to 50% intramural to subserosal and intramural more than or equal to 50% intramural. So this is Figo classification. 0 is intracavitary and 1, 2 are submucosal, less than 50% and more than or equal to 50% involvement of intramural. 3 is intramural. This is Abbott's endometrium. 4 is intramural, which is entirely only in myometrial plane. Subserosal, more than or equal to 50% intramural is 5. 6 is subserosal, less than 50% intramural. 7 subserosal, which is pedungulated. 8 is extrauterine. It includes the cervical lesions, fibroids in the round ligament or broad ligament, and parasitic fibroids. Thank you, ma'am.
That's a nice presentation. You have finished in time. That's a good thing, Pratibha. And just 2 questions only. Now, what do you think is the advantage of this newer Figo classification?
Advantage of Figo, it is helps in treatment purpose, ma'am. For medical management, we can for hormonal treatment, for subserosal we can go for surgical. For intramural and submucosal, which is more than 50% involvement, we can treat medical management.
Not only medical, and also the type of surgical management also, like histoscopic and other things, whether single step or 2-step procedure you have to go, and all those things can plan ahead. Okay.
Yes, ma'am.
Okay. And about this pathogenesis, you could have mentioned a bit about this molecular pathogenesis.
Yes, ma'am.
Have you read about it? What is that and what is the importance of that?
Ma'am, it is hereditary, their hereditary potential to get the fibroid.
What else? What else have you learned about this? Molecular pathogenesis of uterine fibroids. Have you read about it?
Yes, ma'am. That overexpression of microRNA and protein synthesis.
What is the importance of it? Why should we know about it? See, all these pathogenesis factors which you have mentioned are probably this can cause, that can cause, and like that. And this molecular pathogenesis says that, number one, of course, the MET12 gene mutation is one thing. And the tumor is TIC. You have heard about the TIC and the myometrial stem cells. It is actually like a healing process. So when there is a dysregulation of this myometrial stem cells, it results in the multiplication of the cells leading on to fibroid. That is why it is expressed in the different fibroids. Not that in the same woman, the fibroids do not grow in the same, the uterus. They don't, multiple fibroids, they don't grow in the same rate. So there is an individual variation. Okay. And if you go further into this molecular pathogenesis, it can help in future for prevention also. Prevention of fibroid. Okay. Right. And Geeta, anything else you want to ask?
Dr. Pradeepa, can you just summarize the role of progesterone, the effect of progesterone on the fibroid?
Ma'am, actually, as we know, estrogen increases the cell proliferation, and also progesterone also increases the cell proliferation by acting on the progesterone receptors, ma'am. But if we are in treatment, if we are giving GnRH agonist or antagonist for treatment, if we are supplementing with progesterone also increases the rate of progression of fibroid disease, ma'am.
Actually, it does
So
dual
progesterone
action.
is not.
Progesterone has dual action. So it can also inhibit the growth of the fibroid by inhibiting insulin-like growth factor. Progesterone,
but it also increases the chances of.
So it can increase the size as well as it can decrease the size depending on where it is going to act.
Okay.
Yes. And as such, this estrogen and progesterone impact on the growth of the fibroid is still not very clear. Okay. That is why even now, yesterday also I had a patient, menopause 5 years ago. Still she is having 3-4 fibroids of the same size, continue to have that. It doesn't regress just because her hormones level come down. Okay. And this endocrine disrupting factors also must be taken into consideration, right? Okay.
What are the other protective mechanisms for fibroid? So we are telling about the risk factors for fibroid, no? So what are the counterprotective factors? There are certain factors which will inhibit the growth of fibroid.
Regular exercise, dietary factors, and
diet, what should be avoided?
Ma'am?
Diet, what should be avoided? What about weight reduction?
Ma'am, red meat, high fat diet have to be avoided, ma'am. Have to take increased dietary fiber and vegetables, fruits, regular exercise.
Parity is also a protective factor. So fibroid is more common with the nulliparous.
Yes, ma'am.
Okay. Shall we move on to the next speaker?
Yes.
Okay. Radhika?
Yes,
slide
sir.
of the next one.
So next speaker is Dr. T.M. Swati. So she's completed MBBS and MSOG from Tanjavur Medical College, and she's worked as assistant professor in Tanjavur Medical College for 5 years. She's presently working as consultant at NM Hospital Private Limited, Tanjavur, and her field of interest is gynae endoscopy and infertility. And she is going to give us a talk on features and investigations of fibroid.
Good evening, ma'am. Am I audible, ma'am?
Yes, you're audible.
Okay, ma'am. Good evening. I thank Tnfog for giving me this opportunity. Ma'am, I'll start sharing the screen, ma'am.
Swati?
1 minute, ma'am.
He's sharing them.
Ma'am, is it seen, ma'am?
Yeah.
1 second.
Ma'am, please click on share screen, ma'am.
Yes, ma'am. I'm clicking on share screen.
And then click on PPT tab, or on top there will be like screen option. You can click on that and then share.
No, ma'am. 1 second. Ma'am, I'm not able to get the screen.
What it is showing, ma'am?
No, only the desktop picture is only seen, ma'am.
Ma'am, you haven't started share screening, ma'am. So please click on share screen, and then
Ma'am, the Zoom link itself only I can see only you. I cannot see the others.
on below there will be some options, ma'am. Share screen. You can see it, ma'am.
Scroll down.
Yes, ma'am. I'm seeing share screen.
Yes, ma'am. Please click on that, ma'am, and then click share.
Okay, share. Okay, ma'am.
Now please open the PPT, ma'am.
Yes, ma'am. Now is it seen, ma'am?
Yes, ma'am. Yes, ma'am. Thank you.
Sorry. Okay, coming to the features and investigations. Okay, so what are the basic symptoms usually patients present? They are usually asymptomatic. 50% of them are asymptomatic. 30% present with abnormal uterine bleeding, which is usually menorrhagia, mostly in the intramural and submucous type, and metorrhagia in the submucous variety, and polymenorrhea if it's going to be associated with cystic ovaries, and PID. Sometimes they can also present with purulent discharge when you have an infected fibroid polyp. So the other symptoms could be pressure symptoms, which it could lead to retention of the urine, further leading to hydroureter and hydronephrosis, or it could also lead to constipation and intestinal obstruction. Some present with abdominal pain, which could be congestive or spasmodic dysmenorrhea. Acute pain can occur in a torsion of a pedunculated subserous fibroid or hemorrhage or red degeneration in a fibroids, which is fibroid complicating pregnancies, or it can also present as a chronic pelvic pain. The next important symptom is mainly of our concern is infertility, whereas the sole reason for infertility in a fibroid accounts for 2 to 3%, and it can also result in recurrent pregnancy losses. When the size of fibroid is more than 4 centimeter and distorting the endometrial cavity, such as in a submucous fibroid, or it's going to be associated with PID endometriosis, or resulting in anovulation. The fertility rate is very much reduced in the variety of submucous type, whereas subserosal type has not much effect, and intramural type has a slight decrease in your fertility rate. So sometimes patients are asymptomatic and present to you only with an abdominal lump. That is sometimes a rapid growth in lump of the abdomen that is present in a case of sarcomatous changes, or they also present as pseudo-Meek syndrome where you have ascites and pleural effusion. The others could be secondary to anemia, where you have abnormal uterine bleeding resulting in severe anemia and features of anemia. So the signs are mainly general examination also has to be taken into account, where anemia occurs due to prolonged heavy bleeding. In per abdomen examination, if it's going to be more than 12 weeks size, it's a firm nodular swelling mass arising from the pelvis where the lower limit cannot be reached, a relatively well-defined, mobile from side to side, non-tender, dull on percussion, and there is no free fluid in the abdomen. Per speculum, the cervix seemed to be pulled higher up. Per vaginal examination, the uterus is enlarged and nodular. We have to differentiate it from an ovarian tumor. The uterus is not separately felt and transmitted movements will be present, and the notch is not felt. Per rectal examination may help in difficult cases. So per abdomen examination, when the uterus is larger than 12 to 14 weeks, They are very palpable per abdomen. Enlarged uterus may mimic as can be even mimicking as a term pregnancy, whereas in this the surface is irregular, nodular, or it could be bossed, firm, but there will be no Braxton Hicks contractions and no palpable fetal parts, movements, and no fetal heart sounds. The uterine shuffle is due to increased blood supply to the uterus, which has to be differentiated from the umbilical shuffle. So pelvic examination, the enlarged uterus due to fibroids is of variable size, irregular surface, nodular or bossed, and associated cystic enlargement of the ovary may be noted. Enlarged uterus is firm and non-tender, freely mobile up and down and side to side till it incarcerates in the pelvis. Enlarged uterus and cervix always move together. So the diagnosis is mainly from the history, examination, and imaging. So investigations, hemoglobin and blood grouping is important as it could lead to severe anemia. The main imaging modalities are the ultrasound, which is a basic imaging modality which has to be done. Then you have the hysterosalpingography, the SSG, the 3D ultrasound and MRI, DNC when it is going to be associated with endometrial cancer, laparoscopy and hysteroscopy. In majority of the cases, clinical features are very clear-cut. Elaborate investigations may not be required. So imaging sonography is the most readily available and least costly to differentiate fibroids from the other pathology. Usually in an ultrasound, the fibroid appears solid, round, hypoechoic to the myometrium and a heterogeneous lesion within the myometrium, acoustic shadowing with the edges with or without internal fan-shaped shadowing. In the Doppler, a ring of fire appearance is seen. So this is how a fibroid looks in an ultrasound. So this is also a fibroid in the transverse section. So here we see a normal uterus. The other we see a subserosal fibroid where it shows an outward protruding fibroid. The fibroid grows more towards the serosal layer, which can compress the adjacent structures. So this is a transabdominal view of a pedunculated fibroid. So the next thing is here recently, which is coming up, is the 3D ultrasound. In the 3D ultrasound, also in the fibroids are visualized, whereas this is in a 2D ultrasound, whereas in 3D, the extent of involvement to the cavity can be visualized. So this is also 3D ultrasound picture of a fibroid, which shows an increased vascularity. So this is a fibroid, which is a submucosal fibroid with the pregnancy, which is visualized in the 3D ultrasound. So next is your saline infusion sonohysterography, where saline is instilled into the uterine cavity to visualize the submucous fibroids more clearly. So this is how a submucous fibroid is visualized when using a saline sonohysterography. The uterine cavity is expanded with saline solution and then it is visualized. So this is a normal uterus. The above one shows the one with the fibroid. So this is also a similar picture where the fibroid is visualized within the endometrial cavity. So these are similar pictures of the fibroid, which has to be differentiated from the endometrial polyps. Endometrial polyps are also better visualized with your saline infusion sonography. Endometrial polyps are usually present as non-specific ET thickening, endometrial thickening, or focal mass in the endometrium. They can be hypoechoic, isoechoic, or echogenic, whereas leiomyomas are usually well-defined solid masses. Sometimes it can present with calcification and necrosis. So in the hysterosalpingogram, this is a normal hysterosalpingogram. When you have a fibroid, it can be visualized as filling defects. So this shows a filling defect in the uterine. And this is also another picture of the hysterosalpingogram, which can also diagnose a fibroid, intracavitary lesions. So MRI is another modality which is used mainly for mapping. So in MRI, it is usually visualized as well-circumscribed, homogeneous, low-intensity signals on T2-weighted images compared to the myometrium. Sometimes cellular fibroids can depict a high-intensity signals. So the enhancement is usually variable and it's important when planning for uterine fibroid embolization. That is, with more enhancement and more vascularity, they better respond to uterine fibroid embolization. So these are pictures where the MRI shows the fibroid. So this shows multiple fibroid, MRI image showing multiple fibroids. So the imaging sensitivity is MRI is 100% sensitivity, whereas transvaginal is 83, and saline infusion is sonohysterography is 90, and hysteroscopy also plays a role. So in hysteroscopy and laparoscopy, they are both invasive and diagnostic and therapeutic modalities, where it can also be diagnosed and treatment can be done concurrently. So the differential diagnosis could be pregnancy, hematometra, adenomyosis, a biconvate uterus, ovarian cyst and tumors, ectopic pregnancy, pelvic kidneys or chronic inversion. Changes which can occur, secondary changes and complications could be either hyaline, cystic, fatty, calcareous, and red degeneration, which occurs mainly in pregnancy. Sometimes even atrophy and sarcomatous change occurs in 0.1 to 0.8% of the patients, where there is a rapidly growing fibroid with pain abdomen. So sometimes it can the complications could be torsion or an inversion, hemorrhage, and infection. So the association with endometrial cancer is usually 3%, and adenomyosis and endometriosis is 30%, and salpingo-oophorytis accounts for 15%. Thank you, ma'am.
Okay, fine. But thing is that, number one, are you doing routinely HSG as the main investigation in a case of fibroid?
No, ma'am, only ultrasound is the initial first investigation.
Ultrasound. Or if at all you suspect any submucous fibroid, you go for the
Saline.
SSG. Okay, and not HSG, I don't think. Unless and otherwise it is an infertile patient where you want a tubal patency test. But for the sake of fibroid, you don't go for HSG. Okay.
Yes, ma'am.
And MRI, any other advantage?
Ma'am, MRI is used, mapping is done, ma'am, especially when we plan for a lap myomectomy. The site, size, and location is also important. Sometimes it's used in management also, ma'am, MRI focused ultrasound.
And also the degenerative changes also can be made out.
So which cases you will suspect leiomyosarcoma?
Ma'am, when there's sudden increase in the size of the fibroid, when she's presenting with acute pain, abdomen, or bleeding, ma'am.
Which age group?
Postmenopausal, ma'am.
Okay. Can you tell us the causes for infertility in fibroid?
The causes for infertility in fibroid could be either it could be mechanical obstruction, ma'am, leading to the blockade of the tubes, or it could be submucous where it distorts the endometrial cavity, or it could be huge fibroid where the vascularity is increased to the fibroid, compromising the vascularity to the uterus, ma'am, where implantation is hindered.
Only structural cause? Fibroid can affect fertility issues, both structural as well as functional. It can impair it can cause uterine contractility, and molecular level also it can produce some changes.
Yes, ma'am, the peristalsis is reversed.
How will you differentiate adenomyosis from fibroid by ultrasound?
Usually the fibroid is well circumscribed, ma'am. We have a pseudocapsule. It's usually round and well circumscribed, whereas adenomyosis, the margins are not clear, ma'am. And usually it appears diffuse with no clear-cut margins. And sometimes it could be either a globular uterus or either thickening of the anterior or posterior myometrium, ma'am.
Any other changes you will see in adenomyosis?
Myometrial cyst also can be seen, ma'am, sometimes. Subendometrial myometrial cysts can be seen.
Okay. So the endomyometrial junction will not be well demarcated. Whereas in case of fibroid, it will be demarcated. That is, it will be an encapsulated mass and there will be a peripheral vascularity. Whereas in adenomyosis, it will be irregular.
Okay.
Okay. We can move on to the next thing. There's enough time there.
Thank you.
Radhika can proceed to the next. Thank you.
Hello, ma'am. Good evening, all. Nice to see you. A lot number of senior faculty. So nice to hear to the discussions. Thank you for inviting me, ma'am.
Welcome, Chitra.
Ma'am is always connected. Revati ma'am was giving a good feedback and points regarding this. Nice, ma'am. Good.
Thank you. Thank you.
Radhika ma'am, please unmute, ma'am.
Okay, we'll move on to the next session, which is a scientific session. The chairperson, I invite Dr. Anjalakshi ma'am. who is a senior consultant in OG, Chennai, founder president of Tnfog, past president of OGC, governing council member DIPSI, and she is the recipient of the Best Doctor Award from IMA, retired professor OBG from Madras Medical College, and retired professor and HOD OBG Mada Medical College, and she's present in a number of papers in national international conference. Actually, she needs no introduction. We all know her. And a madam who is going to present is Dr. Chitra Tyagaraju ma'am. I invite her. Now, fellowship, she is the fellowship in reproductive medicine and minimal access surgery. She's a certificate course in advanced research methodology in JIPMER. And she
Yes, ma'am. We can proceed. We can
okay.
proceed. Ma'am, allow me to share the screen.
Sure, ma'am. Please start. Sahiti. Okay, ma'am.
Thank you for all this opportunity. I think I think the previous speakers all have been discussed about the fibroid uterus. What matters to us is like 20 to 30% of Indian women.
Full screen.
Ma'am, make it into full screen, ma'am.
Ma'am, I'm already put into full screen, ma'am.
No.
We cannot see it, ma'am. Ma'am, kindly reshare, ma'am.
Reshare, okay.
And what happens, Agiti? Many a times panelists are asking in the chat box, audio not
Yes,
possible for them. Have you
Audio,
done anything for that?
audio is fine, ma'am. No issues.
For us, it is clear. But many panelists said in between that audio is not clear.
சொல்லிட்டீங்களா இந்த இது டாக் முடிஞ்ச உடனே क्वेश्चंस போடுவோம்னா
இது என்னோட
Ma'am, is it okay, ma'am? Now I will start sharing.
No, even then it is not full screen.
Full screen, ma'am.
Ma'am, once stop share, ma'am, I will explain you, ma'am.
Done.
Yes, ma'am.
Stop
While
sharing.
sharing the screen, you need to click on screen option, which is on the top, and then click on share.
I mean, I go for the share screen.
And then there is a tab called screen tab on top of the screen, ma'am.
Okay, I'll go for the slideshow.
Yeah, better go for that.
அது பண்ணணும்.
Okay, ma'am.
No.
Still like that, only no problem. Okay, proceed.
சித்ரா கீழே கப்பு மாதிரி ஒண்ணு இருக்குல்ல அத போட்டு பாருங்களேன்.
அதுதான் மேடம் போடி மேடம் எனக்கு full screen இருக்கு மேடம். I am having full screen here.
சித்ரா proceed பண்ணுங்க.
Let her proceed. Let her proceed.
For the delegates sake, I am telling after Dr. Chitra madam's talk, one questions will be posted. And after Dr. Ramani madam's panel, one question will be posted. For each first prizes will be given. Thank you.
So as I already told, the previous speakers have discussed about the introduction for the uterine fibroid. What matters to most is like
Ma'am,
20
your
to
screen
30.
is not visible, ma'am.
No, ma'am.
No, ma'am. You need to click on this screen option and then share, ma'am.
Screen option.
Screen option like this, it will be there, ma'am, and then click on share so that full screen will be visible, ma'am.
Still not yet seen, ma'am.
No, same way only, doesn't matter. We proceed. No other go.
No problem.
Can't waste time.
Yes, ma'am. That's what. So matters to is like not all fibroid can need some medical management or surgical management because more than 50% are asymptomatic. So according to the classification, what the previous speaker has told, even it matters which is responding to the medical and which responds to the surgical management. And even the symptoms also matters. Just like you have a pressure symptoms or urinary symptoms or a patient, most of the time the medical management occurs for a patients who are having excessive menstrual bleeding or abnormal uterine bleeding, or if it is affecting her infertility. So why it is very important for us, like any fibroid uterus also infertility, patient needs to have a vigorous treatment because it interferes the sperm and ovum transport, deformates the uterine cavity, and can have any corneal fibroid or in submucous fibroid near the cornea, can also obstruction of the tubal ossia. They increases the chances of miscarriage if auto implantation occurs at the site of this fibroid. And also, if it is continuous, it also increase the risk of obstetric complication like PPH can occur, abruption of placenta previa can occur. So this is an algorithm. In the algorithm, you can see we have divided into patients who are asymptomatic or asymptomatic. If it is asymptomatic and if it's less than 14 weeks, nothing to be done. You need to do expectant management. But if it is more than 14 weeks of signs, you have to discuss, because as it's going in size, it might put a pressure symptoms becomes more common, and if ureter obstruction can occur, HUN can occur. So these are the things for asymptomatic women. For symptomatic, you have to like medical management. It can be hormonal or non-hormonal, and in infertility, you have to intervene only if it is an intramural projecting more into endometrial cavity, or it is a submucous fibroid. And if it is diagnosed in the patient with the pre and postmenopausal age group, it all depends upon the wishes of the patient, whether she is to preserve the fertility or preserve the uterus, or in patient with postmenopausal patient, if at all symptomatic, you need to rule out the malignancy, then you can manage accordingly. So these are the various options available for uterine fibroid. I was already told you medical can be hormonal, non-hormonal, and surgical myomectomy or hysterectomy. Other alternatives include uterine embolization or MRI or magnetic resonance guided focus ultrasound, or it is radiofrequency ablations. So I think we have a lot of medical options. I'll just go the pros and cons of each and go to the recent one which has been used now, which are coming into recent dates. So GnRH agonists, as we already know, the first line of management for any patient in reproductive age group we are planning to give is a GnRH agonist. Can be in the reproductive or planning for fertility treatment, or you are already completed family. We know that giving this GnRH, it decreases the initial causes flare, FSH, LHS, and causes the suppression of LH and FSH. So by doing so, it decreases the sex steroid hormone production. So it's shown that it reduces the fibroid volume by as low as 30 to 40%. Most of the time when we give GnRH, we give pre-operatively, so that we decreases the blood loss, increases the hemoglobin, and also convert the abdominal procedure to vaginal procedures. But what happens when you give GnRH, because of his down regulation of LH and FSH, these patients can have vasomotor symptoms, and they can have early hot flushes or decrease in the bone mineral densities. So to counteract this, we have to put an add-back regime for this patient, and studies have shown that you should not give more than 3 to 6 months. And the recent Cochrane review has told us, yes, can be used because can improve both pre-operatively and post-operatively, and it reduces hemoglobin levels, it reduces operative time and shortens the duration of hospital stay. It is also shown that it decreases the menstrual bleed and reduces the fibroid volume by 50%. And according to the current status therapy, we have seen that though it has advantages, what I've mentioned, it should not be recommended before conventional laparoscopic myomectomy, because it's very difficult to define the plane when doing the laparoscopy. And because of side effect profile, we should not give more than 3 to 6 months. If at all we are giving, please give that add-back regime along with that low dose OCPs. Now, new thing which is coming into the market is a GnRH antagonist. As I already told you, it is a competitive with the endogenous GnRH for pituitary binding sites. Due to the lack of any interactivity GnRH antagonist, the characteristic initial flare, what you see in the agonist, is not in the antagonist. So what happens? It causes immediately suppression of LH and FSH, and its activities is usually dose dependent, and it depends upon the size of the fibroid, the size and the level of the dose should be given to inhibit the levels of inhibitors to reduce the size of this fibroid. It has its side effects, flushes, and headache. Various studies have shown that yes, it can decrease the size of the leiomyoma and also the symptoms. But once you stop the treatment, the chances of recurrence of leioma can occur. Now the elagolix or relugolix are only GnRH which has been FDA approved. I am just going through various studies where this has been used and have shown to be having a very effect on the uterine symptoms, volume, and even the blood loss. One study, which is a systemic review meta-analysis, which is where the elagolix was used versus placebo in one group, and elagolix with estradiol, non-estradiol in other group, have shown that this elagolix to be very effective in reducing the heavy menstrual bleeding caused by uterine fibroid. And when you give combination with estradiol and non-ethylene acetate, it is also elevate the hypotensive side effects in the premenopausal age group. And one relugolix combination therapy. In this patient, they're given placebo and relugolix combination therapy. And in this study, it has shown that in the relugolix combination therapy, 73% of the participants, the trial L1, who got a combination therapy, and 70% the L2, where they got a delayed relugolix combination therapy, there was a significant reduction in the menstrual blood loss, and compared to 19 to 50% where placebo used. So they concluded that giving relugolix combination therapy resulted in significant reduction in menstrual bleeding as compared with placebo and preserved bone mineral density. And one more antagonist is the linazogolix, which was used in 2 trials, Primrose 1 and 2 trials, when they given that in various dosage, first 100 milligram along with estradiol, not ethidron, and group 3 200 milligram, and group 4 is 200 milligram linazolix along with the non-ethidron. They found that in all the places where linazolix was given, there was a woman, they showed that there's a significant reduction in heavy menstrual blood loss. So whether you give OCPs or not, linazolix have shown to have a significant reduction in heavy menstrual bleeding. So this can be considered in the patients who are having, whom we are worried of this worrisome of bone mineral density. And nice guidelines tell that relugolix combination with estradiol, non-ethidron acetate is recommended with its marketing authorization as an option for treating moderate to severe symptoms of uterine fibroid in adults of a particular age group. Androgens, as everyone knows, androgen is only the danazol, which has shown to have an effect, very good effect in cases of fibroid or endometriosis or this thing. But what is the problem with androgens is that it causes this danazolitis. It causes an androgenic, more androgenic symptoms. It produces amenorrhea. It causes a block. It produces amenorrhea. It causes all the symptoms of hyperhidrotism, hoarseness of voice. So the danazol connected therapy, yes, when you give danazol, no evidence have been shown with any ascites that benefits danazol outweighs risk treating uterine fibroids. Why I'm mentioning in our recent is nowadays danazol vaginal ring has come. It has shown to have a minimal side effects of the androgenic symptoms and has been used in patients with even endometriosis or in patients with fibroid uterus can be used. LNG, I am sure LNG has been used for many of the people, for the patients with the dysfunction uterine bleeding or in patients with abnormal uterine bleeding. It is a T-shaped device which contains 52 mg of LNG, which releases 20 picogram every day. It is almost an alternate to hysterectomy for menorrhagia. Nowadays, you have the Preserve Uterus campaign going on, where menorrhagia, in patient with menorrhagia, instead of doing hysterectomy, LNG can also be used. And now recent have shown that this patient can be used even in fibroids, adenomyosis, endometriosis. And various studies have shown that it is contraindicated in patient with having submucous fibroid, but in patient with having any intramural fibroid which is not disturbing the uterine cavity, LNG can be used. And what are the observed studies?
Ma'am, slides are not moving, ma'am.
Now, ma?
No, ma'am. We are in the 8th slide, ma'am.
Oh God.
Slides are not moving, ma'am. It's just in the treatment algorithm, actually.
Have you come to LNG? No.
No. It's in the treatment algorithm.
Can I stop and reshare again, please?
Okay,
Yes.
ma'am.
I don't know what is the problem. Can we see now, ma'am?
Yes.
Yes.
Ma'am, it has come to LNG, no, ma'am?
Yes.
Yeah. So when the LNG is the one which is a treatment option in non-submucous small fibroids, especially to reduce the symptoms of not only the symptoms but also to the uterus volume. And when they found that whether women were satisfied with the LNG or not, they've shown that it is quite viable and effective treatment, and there was high rate of patient satisfaction in appropriate selected patients. And it also shown that LNG is effective in controlling heavy menorrhagia, and even a patient who are having irregular frequently uterine bleeding in the presence of myoma can also be used. Can be used to treat this patient, but it doesn't have any significant effect on the size of tumors. That is very important to note. It can reduce the symptoms, but it doesn't reduce the size or volume of the fibroid uterus. So LNG can be used in women with intramural fibroid but do not desire pregnancy or near term. COCs, yes, we have been used COCs as a first line of management in patient with fibroid before, but due to everyone knows mechanisms of action of COCs. What I want to do, when you compare the COCs with the LNG, it has shown that LNGs is better in controlling the heavy menstrual bleeding and in the patient satisfaction, who improve the quality of the life compared to that of this COCs. And this is also one study which have shown that difference between LNG and COCs. Both had a failure rate of around 23% and 37%, though their rate of failure was similar in both the groups, but LNG was more effective in reducing the mean blood loss than COCs in these patients. Please read. Okay, when we are giving the COCs, we always think of this progesterone dominance. Progesterone dominance is very important because nowadays progesterone dominance have shown to reduce the size of fibroid. One study which has shown that COCs containing gestodin have known to decrease not only blood loss but also the size of the uterine volume. So COCs, tranexamic NSAIDs are used mainly for the symptomatic treatment and to reduce the bleeding and dysmenorrhea. Coming to the main thing, that is selective progesterone receptor modulators. So we know that this steroid progesterone receptor ligands are able to induce both agonist and antagonist activities. They act different on different tissues. One tissue can be agonist, other tissue can be antagonist effect, and is very effective in a various biological activity like contraception, preoperative treatment, also in cases of endometriosis. The two main drug which has been very well established in upcoming in the patients with fibroidosis, mifepristone and ulipristal, and other things which are in trial is asopresinol. I think down a recent what I saw the study was even asopresinol studies have come where it can be used in the management of fibroid uterus. So mifepristone is well known for anti-glucocorticoid activity and has beneficial effects like decreased volume symptoms of the fibroid also, and but also determinant effects including the endometrial hyperplasia also be shown in few patients with mifepristone. Ulipristal acetate, it shows to control the bleeding, fibroid size, and improve the quality of life without any showing significant changes on endometrial hyperplasia. It is approved in both in Canada and Europe as a pre-surgical therapy for patients with fibroid uterus. So few studies which I have put up for the patients for mifepristone, ulipristal. One study which has used, I think when we had a last time preserve the uterus, many people are not using mifepristone. They told it's not available. Yes, it is very difficult until unless you find out the company which is having 25 milligram of mifepristone, or it's very difficult to break the 600. So one study which has used 5 to 50 milligram various dosage for 3 to 6 months have shown to reduce the uterus volume by at least 25 to 50% and leiomyoma volume by 75%, and prevents the severity of dysmenorrhea, pelvic pressure, and menorrhagia. And overall, the patient of rate of amenorrhea after 3 months of giving mifepristone is 63 to 100%. And one more study in the pre-menopausal age group, when mifepristone was given in dosage of 2.5 to 25 for 3 to 6 months, have shown to reduce the fibroid volume, uterine volume, and also elevates the symptoms. But they did not find any difference in the rate of atypical endometrial hyperplasia between mifepristone or the placebo group. In one of the Indian studies which have been done, it has shown that when you give mifepristone 25 milligram per day for a duration of 3 months, they found there is a significant reduction in the amount of menorrhagia, dysmenorrhea, uterine and fibroid volume, and almost improvement in the quality of life with the increase in the hemoglobin levels. So when they compared mifepristone and GnRH analogs, they found that there was a marked relief with significant decrease in visual analog score in both the patients, but treatment with mifepristone daily for 3 months significantly reduced the bleeding, uterine volume, and myoma volume with less side effects of that of these hot flushes which is occurring GnRH agonist. Coming to the ulipristal, they did one study where they gave 5 milligram in one group, 10 milligram in one group, and placebo in one group. They found there was significant reduction in the patients' controlled bleeding, 91 to 92% compared to 19% in the placebo group, and also significant reduction in the volume of the fibroid compared to that of the placebo. In one more study, they compared this different doses of ulipristal along with the GnRH, and found that the controlled uterine bleeding is better in all the 3 groups, but much better in ulipristal group rather than GnRH group. And they found that they were non-inferior to once monthly rupraride in controlling uterine bleeding and were significantly less likely to cause the hot flushes. When they give the long treatment, like a 3 months course for a longer time, they found that repeated 3-month UPA course after 3 months and again giving 3 months altogether 6 months, they found that it is very effective in controlling bleeding and shrink the fibroids in patients with symptomatic fibroid. And when you found that safety and efficacy of repeated dose, one more study showed even giving for 12 weeks courses for a longer time are shown to control the bleeding, reduce fibroid volume, and restore the quality of life in these patients. This is the one more study which contained the leuprolide with urate acetate. Even that have shown that effect of urate acetate, how heavy menstrual bleeding shown to be compared with that of the leuprolide, and there was no notable adverse effects, and the incidence of which is possible, it was comparable between both the groups. So uric acid can be given, but now we have known that it causes a some studies have shown that it causes a liver function abnormalities. So if you find that, immediately it should be stopped and the patient should be monitored until the levels come back to normal. And whereas the Society of Obstetricians and Gynecologists of Canada also have recommended giving of sperm in the management of uterine leiomyoma. So, expert opinion said baseline liver function is advised before starting a ulipristal, and treatment is deferred or suspended when the results are more than twice the normal. And this is followed by periodic monitoring of liver function tests during and after the course of UPI. That's the same thing which I do. Coming to this non-hormonal, nowadays non-hormonal habits more taking weightage than the hormonal because of the less side effects and is as effective as in hormonal. So various things like growth factors, early life exposure, inflammation are the key factors in giving non-hormonal therapy. And very important is this non-hormonal therapy have shown to act on the both progesterone and estrogen receptors. These are the one catechol or methyl transferases and transform growth factor B. These are the new target for the fibroids, and it can be initiated on any day of the menstrual cycle. This is a mechanism of action, how it occurs. One is the tryptogerium welfredi, which is act on the progesterone and estrogen receptors, decreases aromatase enzyme, and this is a epigalactin, which is present in the green tea extract, and decreases COMT expression, and vitamin D3 decreases the transdermal growth factor B3. So coming to the first, like one study to observe the therapeutic effect of pterygium welfredi hook, they found 65 patients and gave this treatment for 6 months. They found that this tryptogerium welfredi hook may be effective therapeutic effect for leiomyoma with very few side effects. And one more, which I've already told, that green tea extract, which is epigalactostatin gallate, and they found that this decreases the symptom severe score and increases the quality of the life in this patient with uterine fibroid. And this quality of life dramatically decrease with increase with when they're given for more period of time, for at least for 4 to 6 months. This is the same thing. This shows promising as a safe and effective therapeutic agent for women with symptomatic uterine fibroid, and it's a simple, inexpensive, and orally administered therapy which can improve overall quality of life with patient with fibroid. Other thing is the vitamin thing. Now, vitamin D is used in so many patients, even in the patient with PCOS or in endometriosis or in adenomyosis. This is going to play a very important role. They have shown that 2 patients, one group received vitamin D 15,000 IU every 2 weeks, and group A received placebo, and they found that administration of vitamin D may reduce the side effects, size of the leiomyoma, and it seems that vitamin D administration is effective way to treat the leiomyoma. And when they gave vitamin D with the epigalactostatin gallate, they found that the combination supplementation of vitamin D3 and EGCG seems to be an optimal approach for the management of myomas and correlated symptoms. Even the guidelines have shown that documents the use of this tryptogerium welfredi in uterine fibroid because it has shown greater reduction in the fibroid volume and even the uterine cell. Surgical options, everything, I think you know, myomectomy, hysterectomy, myelinosis. What I want to stress on this thing, uterine embolization, which had been used previously for patients with dysfunction uterine bedding, abnormal uterine bedding. But nowadays, I think even with the fibroid uterus, submucous fibroid, internal fibroid, small cells, or not willing for surgery, uterine embolization can be done, and radio frequency ablation and magnetic resonance guided focus ultrasound. A few words, uterine embolization, we know that polyvinal particles have been injected into the femoral sheath, to the femoral vein, which goes and blocks into the uterine vessels branching, and that causes the necrosis, even both when the both arteries get occluded. And it is a non-surgical intervention done along with the interventional radiologist. But what we have to counsel the woman is that the serious side effects, which can be 4 times more than that of the hysterectomy, sometimes that can occur because of embolism, or septicemia can occur because if there's any organisms present in the blood vessels, their toxins may result in a multiple organ failure, and infection from the depth of these tissues of the fibroid, they lead to endometriosis, and but that might result in lengthy hospitalization. And sometimes inside of this misombolization of these particles can go into the other organs that can lead to multiple organ failure. And since we are going to block the uterine vessels, sometimes it can go into the ovarian vessels and might cause ovarian damage and also causes decrease in the ovarian reserve. So what we are thinks it can cause menopause, iatrogenic menopause can occur, cessation of menstruation, follicle stimulating hormone elevated to menopausal levels can occur if after giving uterine embolization. We should also known as post-embolization syndrome, which is characterized by acute and chronic pain, temperature up to 1 or 2 degrees, malaise, nausea, vomiting, severe night sweats can occur. So patient should not be discharged immediately. You should keep the patient at least for 3 days to see for this symptoms and can be treated accordingly. Some patient can also have a vaginal foul spring discharge because of the necrotic tissues which may remain inside the uterus. So radiofrequency ablation is a minimal invasive procedure which involves inserting a needle-like device into the fibroid through the abdomen and heating it with a low frequency electrical current. This is known as Hall's method, and it is going on in trial. It has shown that this electrode which penetrates the fibroid, it burns the cells and eventually get reabsorbed by the body. And this device also causes the incision to minimize the bleeding. However, it should be done under general anesthesia and patient can go home on the same day. This MRI guided focus ultrasound, we already know that it can be focused via the lens, and there's a curved transducer will be there, and which into a small zone from where the what you call the high intensity focus sonic energy is released to those fibroid, which causes destroy or damage the tissues and via the ablation. So this I don't want to go. And the HIFU, it is same like how it works, where the acoustic wave propagates to the tissues, part of it is absorbed and converted into the heat. With this focus, very small focus can be achieved deep into the tissues, and tissue damage occurs as a function of the temperature to which the tissue is heated. And second, how long the tissue is exposed to the heat level is referred to as thermal dose. Advantage of all these procedures: no scar, can be done as daycare procedures, short hospital stay, less chances of infection or of complication, early resuming to the activities. It interferes with least with the everyday life of the woman, can be done in multiple settings. Repeating this procedure also has a lowest risk. These are the various aspects they compared with uterine embolization, that of the hysterectomy. Most of the patients were more happy with the hysterectomy, and some patients were happy with the uterine embolization. But the problem with uterine embolization is that the symptoms recurred and patient went to surgery, and sometimes the patient have their premature menopause. So I like to conclude that this uterine fibroid is a benign tumor. It can be managed medically, surgically, but surgery has its own limitations. Can be given hormonal or a non-hormonal therapy. But whatever treatment we are giving to the patient, it should depend. It should be individualized, depends on the patient age, the signs, symptoms, whether there's you need to have sustained reduction on the fibroid uterus, where you need to improve the fertility of the patient, and always think of any treatment you're giving, try to minimize the side effects of patient. And what are the things I've told? Advanced procedures, ancillary procedure which can be used. It has its own disadvantage, like if you go for surgery, patient risk of anesthesia and surgery. If you focus ultrasound, it doesn't produce tissue for diagnosis, so can be lead to delay in diagnosis of any hyperplasias and malignancies. Uterine embolization, diagnostic delay can occur 13 to 15 months. Pain, fibroid recurrence, potential ovarian failure, or abnormal placenta development can occur with this patient. Risk of hysteroscopic resection. It can also raise risk of developing uterine sarcoma after resection of endometrium. If at all you're not taking of that place resection, it can show that leaving behind the tissue which are having high risk of hyperplasia can lead to a malignancy of 0.1%. Laparoscopic myomectomy, again we know if you don't do the correlation properly, if the spillage also have lead to high incidence of leiomyosarcoma. Hysterectomy, you go, again there's a risk of morbidity, long-term complication. So we have to plan individually depending on the signs and symptoms. This is a medical management. Thank you so much.
Thank you, ma'am. That was a wonderful presentation, ma'am.
Yeah, I wanted still into surgical these things, but there was a time limit, so I told Sampath madam, I'm going to talk only few things of medical and little bit of ancillary things. Surgical anyway, that is itself is a big thing. So
very interesting.
I hope. The one thing what I've seen, madam, many people are not using that mifepristone and ulipristal acetate. So that's the only thing which can be given for this reproductive age group or premenopausal woman, ma'am. Yes, ma'am.
Chitra, Mifejust is available as 25 milligram tablet. I'm using a lot, especially nearing perimenopause. No, it isn't.
Ma'am, yeah, you please tell here on this, which is a company, so that many people are asking us where it is available. In one of the countries, no one knows that 25 was available in Pondicherry.
25 is available. See, it is actually much safer than ulipristal. You need not go for the LFT and all those other things. And it
True, ma'am.
I think it is Fibroid, isn't it, Ramani?
Fibroid.
Fibroid.
Both are same, madam. And one more thing is, now we have an ultrasound guided radio frequency ablation. that is coming into vogue. I saw that demonstration in recent Sooth conference, see where they are just putting it like how we do the oocyte pickup needle. No, they are putting
Yeah.
the radio frequency
True, madam.
probe into the transvaginal thing, and this
And
probe is
heating up.
pushed into the fibroid.
Fibroid, yes.
We wait for some time and beautifully it lyses. So that is the latest one because it can be done as an OPD procedure with minimal
True, madam.
sedation, and there is no cut or anything coming in between, and the needle is just pointed at the fibroid level.
Fibroid only.
So it doesn't
But the
cause
cost
any
factor,
damage
only
to
the
the
drawback is a cost factor, madam.
Yes, yes. It's
Only the
a
drawback is
one time, single time. That is, it is a disposable one. Maybe in days to come, we will get.
Yeah, multiple users, the cost will come down.
And again, regarding ulipristol, I think DCGI has agreed to for the use of ulipristol in selected cases.
Yes, yes.
Not that it has banned it. You can use.
But madam, I'm not getting a ulipristol only, madam. We want to give at least in the monitoring liver function test.
It is available. It is available. It is available.
It is available, but you have to do the LFT and then proceed cautiously.
Yeah.
That is it.
It is available as uliprist.
Correct.
Okay. Then again, medical management. Now you have already explained regarding this elagolix, relugolix, and linsagolix, and elagolix and relugolix. Actually, it is a common drug both for used for endometriosis.
Endometriosis and this thing, yes, true.
Fibroids. But the thing is, with the use of ulipristol, the textbook description says that the size of the myoma goes down to 60 to 60%. I don't think so. Maximum, it will get reduced to 30%, 1/3, or maximum 40%. Not beyond that, but patients are totally asymptomatic. The bleeding stops. So that is the only advantage with that. Then you are mentioning about this danazol, no? Danazol, vaginal tablets. See, the oral tablet can be used vaginally or rectally. But
okay, ma'am.
100 milligram, that can be used for this also, like how we use for deep infiltrative endometriosis.
Have you used, madam? Have you used and you found some effect?
I have not used it for fibroid, but I have used it for endometriosis. But anyway,
how you use, madam?
You just use the same 200 or 100 milligram tablet. You keep it vaginally or rectally, and especially it doesn't inhibit ovulation also. So that is one major advantage. Pregnancy can be, the patient can become pregnant with that. And I think you have done a wonderful job, Chitra.
Oh, thank you, ma'am. Thank you. All your following. Thank you so much, ma'am. Thanks for the opportunity. Sampath, madam, Ramani, madam, thank you so much.
Sampath, shall we move on to the question? Number one question, I have 2 gifts for the persons who are going to answer. First person who's going to answer.
Ma'am, shall I launch the first question, ma'am?
Yes, yes.
If first question is what Sampath madam had sent. What yeah. Okay. If they had listened to the talk, definitely they would have been able to do it perfectly.
Host and panelists cannot vote.
30 seconds for each question.
So there is
I request all the delegates to actively participate in this. 5 more seconds.
It is not asymptomatic treatment. Treatment of asymptomatic fibroid.
Time up.
Treatment of asymptomatic.
Yes, ma'am. First question.
Up to 14 weeks we can give, ma'am. If 14 weeks asymptomatic.
Asymptomatic up to 14 weeks, we don't do anything. Okay, shall we now move on to the panel discussion, case scenarios on fibroid? I have great pleasure in moderating this. You take all these things here, moderating this panel on fibroids, and with me I have eminent panelist Dr. Guma Velmurugan, who is the Secretary of Trichy OBGYN Society, Managing Director and Chief Consultant, and Dr. Chandra Ponnusamy, who is a Senior Obstetrician and Fertility Consultant from President of Namakal Society. Next, Dr. Mahalakshmi, Associate Professor from Theni Medical College and laparoscopic surgeon, and then Dr. Vijay, who is also a postgraduate teacher from Madurai Medical College, graduated from Madurai Medical College. Currently, I think she is at Dindikal Medical College as an associate professor of OBGYN and has got a practice of more than 23 years. And Dr. Jasmine Rajesh Tilak is from Tirunelveli Medical College, undergraduation, from Madurai post-graduation, infertility training from Simar, and Thuthukudi, present secretary of Thuthukudi Foxy. Next. I think I will share my screen. I have simple cases. Am I visible? Is my screen visible?
Yes, ma'am.
Yes, ma'am. Okay. So, I think the classification of, just for the introduction sake, I have put the classification of fibroid, what has been described by the previous speakers. And ST classification of submucous myoma alone, that has also been a part of it, and they have discussed. Now, straight away coming to the case 1, Mrs. Sharmila, 36-year-old female, came to us with complaints of menorrhagia and secondary infertility. Her menstrual history was, just last month I had this patient, and her LMP was 21/3/24. Marital history, married since 17 years, and she's a known case of diabetes. And obstetric history, she has previous 3 spontaneous abortions, 17 years back, 15 years back, and the last one in 2021. And she has taken some homeopathic treatments for diabetes. She is moderately obese, height of 150 centimeters, BMI of 31. General condition is fair, non-motensive, no thyroid dysfunction. Clinically, breast and CVSRS NAD. Speculum examination, cervix is healthy, and then uterus is antiverted, bulky, and the fornices were free. Ultrasound was done previously. That was, she came to me only last month. It was done in the last year, 7th month, which showed bulky uterus with multiple intramural and submucosal fibroids. So, on investigating her, she was not anemic, urea creatinine, RFT, thyroid function test normal, but she had a very poor glycemic control in A1C of 11.7, viral markers negative. So, I have admitted her for control of diabetes, and I planned her for a diagnostic histolab as she was keen on pregnancy. Okay, on histolaparoscopy, the intraoperative findings, she had a submucosal myoma that was noted and attached to the left lateral wall. Size was 3x3. Uterine cavity was polypoidal, and uterus was also adenomyotic on laparoscopy, and bilateral ovaries were adherent to PVD, sigmoid colon, and pelvic wall. So this is the hysteroscopic view. You can see a beautiful submucous myoma arising from the lateral wall more towards the lower uterine segment, and the background endometrium was slightly hyperplastic. Otherwise, nothing was wrong. And this patient, what is going to be the management? Dr. Uma?
You have to remove the fibroid, madam. Remove the fibroid.
The fibroid. So you need to go for hysteroscopic thing. See, you can, along with that, you could see multiple small polyps, which are all evidence of hyperestrogenism. So now the next question is, when you are going to do a hysteroscopic resection, what are the things you will observe, and what is the current you will use, and what is the media you will use?
I mean, nowadays we have moved on to using saline with the bipolar.
Yes.
So that is, I mean, previously when we were using a monopolar cautery, that is when the glycemia, I mean, we were forced to use glycine. But nowadays it's saline with the bipolar mode. That is the safer and easiest way.
See, what is the advantage of using saline with the bipolar cautery?
You can prevent the fluid overload as well. The
fluid overload, pulmonary edema, and shift. That is, hyponatremia can be avoided. But this patient I had, because I don't possess one bipolar cautery, I have done it with the monopolar only, using glycine as the medium. Okay, then everything was cut, and the final view was, see, as you are going to go for the resection, do not remove the scope nubbin. See, entirely you finish it and then you remove the scope. That is the one. Otherwise, there will be leak of tissue.
The view will be lost and you'll be losing the fluid. And every
so this
time
is
when you
the
come out
final view. And I had to use 1 or 2 strokes to make the cavity entirely normal. So my next question is, so this patient, how will you follow up the patient? So I will just show the laparoscopic picture also. Laparoscopy, the patient had I think adenomyosis. So this was an adenomyotic tissue with an addition of posterior uterine wall, and you can see some endospots also. So this is okay. So now how we are going to manage this particular patient? Post-operatively, how will you manage this patient? Dr. Chandra, she is keen on conception. You being an infertility consultant, suppose if she is coming to you after removing the submucous myoma, what are you going to do?
Yeah, good evening, Dr. Ramani. Since she is more keen and actually she has come for secondary infertility, and already we have cleared this uterine endometrial cavity fibroid. So, actually,
next, what will you do?
Yeah, next I will see the patency of the tubes also.
Okay. Her ovarian reserve is only very, very poor, less than 1. 36 years, 37 years she is. She is still,
AMH is low.
Yeah.
Okay, then
she has adenomyosis also.
Adenomyosis, endometriotic spots, additions.
Yes.
And just give her a dose of one or two doses
treatment.
of
What's the latest diagnosed I'll put her on because she's keen on thing, and we have to treat the endometriosis and adenomyosis also.
Well, give us 2 or 3 doses of GnRH agonist, madam.
Yeah.
Downregulate her and go for ART rather than wasting time.
Okay, so that is before that we have to control the sugars, and then you wait for 2 or 3 doses, which will cause the lessen the adenomyotic spots also, and then she is planned for ART. Now the points for discussion are management of submucous myoma. I think we have discussed it is always hysteroscopic myomectomy, and then again we have 2 more subdivisions. No, Dr. Vijaya. What will you do if the subdivisions, that is the submucous myoma is type 1 or type 2? Figos type 1 or type 2?
You have to remove it, no?
Yes, you remove it by hysteroscopy or by laparoscopy. I think hysteroscopy is sufficient. Yeah, hysteroscopy we can remove the submucous myoma either if it is Figo 1 or 2. Then my next question is, instead of having a single myoma, submucous myoma, if she has multiple submucous myoma, say 3 or 2 or 3 or 3 or 4 in all the walls, fundus, anterior and posterior wall, are you going to change the plan of treatment?
No.
Dr. Jasmine, are you going to have all the myomas resected in the same time?
Madam, I would like to go for a resection of the myoma, madam.
You want?
Because, since it's desirous of pregnancy, not at every time, madam. If it is very small, we can leave and we can put them on GnRH and we can wait and see. The possible myomas can be removed, madam. If it is amenable to everything we remove, there can be chances of this post-operative over-usage of cauterization and the other things. There can be side effects of which, okay, very small, we can, if it is not amenable to removal, we can leave it and give a GnRH and wait and see, madam.
See, my question is, suppose if you have a myoma in the fundus, anterior wall and the posterior wall, would you like to remove the myomas at the same time?
What could be the size of the myoma, madam?
Oh, say all are 2 or 3 centimeters.
Okay.
You didn't catch my point. See, would you like to remove one after another in the same sitting, or would you put it in the different sitting?
All are submucous or?
All are submucous.
Okay, madam. I will try to remove, madam.
See, but what happens is, if you are going to try remove both anterior myoma and posterior myoma, all those raw areas, no, the chances for Asherman is going to be there. So you be always careful. If you want to remove, Maybe you remove 2 myomas which are on the same side. And then post-operatively, what will be the management? You want to put the patient on a copper T, to put the
Yeah, madam,
patient.
definitely. Post-operatively, I will put the patient on copper T, madam.
Copper T. Anybody wants to differ this opinion, or all of you put the copper T?
LNG is better, no ma'am, to prevent
LNG is better if the patient has got bleeding, menorrhagia. Otherwise, Uma,
Madam,
would you
it should be
like to
more
put
safe.
copper T or LNG IUS, or would you prefer some other drug?
If there is, I mean, something like a lipus loop available, like an inert device, like olden days, that would be better option.
Some inert device, madam.
But the answer is
no. Her question is intrauterine device, any device. Are you in favor of putting that or something else? That is her question.
I mean, you can put in a Folis or something during the post-operative.
If there is only bleeding. Otherwise, I have done a clean job in this. As in this case, there was not even a drop of blood, and final view was outcome was very good. Would you want to have a Foley, or would you want to have a lipis loop, or if you want to have an inert copper T or a thing? See, I think I don't need anything to be put in because there is no advantage according to the literature evidence. See, if you want, if at all you want, you can put the patient simply on some estrogen. Can be given, so that will smoothen the surface. Okay. So, anybody can you tell what are the complications of hysteroscopic myomectomy?
He said this Asherman's syndrome.
Asherman's, then electrolyte imbalance,
perforation,
and
intravascular escape of glycemic overload.
That is only causing electrolyte imbalance. Okay, hyponatremia will be severe and the patient can go in for all sort of problems. Okay. Okay, then post-operative care, I think we have discussed. One is one group of patients, one group of the panelists want to go for some inert drug. But my preference is I don't give anything except for sometimes I put the patient only on Proguanova. Okay. When can the patient plan pregnancy after submucous myoma resection?
The next period.
How many days? Months we need?
6 months.
At least
2 months.
2 months.
I mean, she should resume her periods and assess for the endometrial.
After a cycle, madam.
Then after the next period, she can plan for the pregnancy.
Maybe 1 or 2 cycles gap, which can try to improve her hemoglobin and regularize her cycles. Maybe we can plan pregnancy, because even for a laparoscopic myomectomy, we ask the patient to wait only for 3 months duration. Okay, like somebody was telling about the role of medical management in submucous myoma. What is the medical management would you like to give in submucous myoma? Small submucous myoma.
You want to try ulipristal?
Jasmine was telling.
Ulipristal. Anybody wants to try? Yes, we can try.
Yes,
Any medical management. You can try with GnRH analogs. You can try with ulipristal, or you can try with GnRH antagonist, which is going to come. Then mifepristone. All those things can be tried. But it again depends upon how much it is going to involve the cavity of the uterus. Okay. So this particular patient has got associated adenomyosis. So is it going to alter your treatment if the patient wants to conceive through IVF?
You would downregulate her for at least for a few months, madam, 3 months at least, so that the adenomyosis also reduces. Because we know that even with after doing ART and embryo transfer, if the adenomyosis is there, it does affect your chances of success of pregnancy.
Okay. So that I have a separate case on adenomyosis. Though today's topic is fibroid, I have added one case of adenomyosis because this is the month of adenomyosis. April, March is the month of endometriosis, and April is the month of adenomyosis. Chandra, I think your discussion is being heard. Then, okay, then uterine fibroids management, I think we have mentioned. So ideal treatment for uterine fibroid should satisfy the three goals: relief of signs and symptoms, sustained reduction of fibroid size, maintenance and improvement of fertility. And therefore, we need a safe, new, non-invasive method which can reduce the size as well as provide symptomatic and long-term thing. Now, you tell us, I think this we have completed indications for medical therapy. Apart from this case, when is medical therapy, that is ulipristal, is ideal? I think Dr. Chitra has mentioned this in her lecture.
If you want to go for surgical treatment, so you can reduce the size of the fibroids before going in for surgery for a few months.
You can. Maybe you can convert abdominal hysterectomy to a vaginal or a laparoscopic hysterectomy. And I think submucous myoma, the only answer is hysteroscopic resection. Nothing else is the treatment that we have to understand. Then nearing menopause, when patients are not suitable for surgery for medical reasons, because nearing menopause, the patient will be having maybe having some metabolic disorders or diabetes or hypertension or CAD. Those patients who are not fit for surgery, maybe they can try for that medical management. And the initial, when they want to correct anemia also, they can use medical management. So this is the fibroid overall management. I think this slide has been already discussed by Dr. Chitra. Like first thing is to control the bleeding. Tranexamic acid can be given, NSAID, oral contraceptive she has mentioned, and progestins, oral or progesterone containing IUCD, and this is GnRH analogs and sperms. And surgical option is so many things. You can go for, when the patient has completed the family, we can go for hysterectomy, otherwise myomectomy. And non-surgical alternatives also she has mentioned a lot. So these are the drugs which are available for medical management. And this is the algorithm. Again, this also she has shown to us, the algorithm, how to manage asymptomatic. That was a question asked. Up to 14 weeks, we can wait. Asymptomatic myomas, you can keep on observing. Only on the symptomatic myoma, in premenopause and postmenopause, you can divide, and then you can, based upon the need for fertility or need for retaining the uterus, or in the perimenopause, postmenopausal period, maybe we can go in for a surgical radical surgery. So this I will skip. Ulipristal. Now, anybody, can you tell me how you should use ulipristal? You know, it is a sperm, selective progesterone receptor modulator. What is the dosage and how it should be given?
It's the dosage is 2 milligrams. You give it every day.
No, not 2 milligram. This is 5 milligram or 10 milligram. 5 milligram or 10 milligram. Commonly used as 5 milligram or 10. Either thing we can use. Okay, then go ahead. How will you use it? It acts upon the progesterone receptor sites. Okay. How to give that dose?
Orally.
It should be given orally. See, you know, Chitra had mentioned about the action on endometrium. It might suppress the bleeding, and it can thin out the endometrium. Sometimes progesterone-induced endometrial changes can appear, so that too, especially when you use mifepristone, the endometrium will be thickened. But you don't bother about it. Nothing to worry. So the dosage is like this. Like we have 4 trials on ulipristal, Pearl 1, 2, 3, and 4 trials, where to study the use of ulipristal. In Pearl 1, it is just a reduction in fibroid volume. Pearl 2 compared to UPA with leuprolide. Pearl 3, long-term efficacy of 10 milligram. Pearl 4, it is even a much longer time. So the conclusion of the trial is bleeding gets controlled very rapidly, amenorrhea occurs, and the volume reduction is about 21% at the end of 13 weeks and 54% at the end of post 3. Okay, then it can improve the quality of life. So the contraindication, main contraindications for ulipristal. What is the main contraindication?
Liver problems, patient with liver disease.
So we are supposed, when you are going to start the patient on ulipristal, what are the precautions you should take?
Do a liver function test before.
Liver function test. Okay. See what I have showed in the picture slide. Any genital bleeding, the cause should be ruled out. Rule out malignancy, and it should not be used in postmenopausal women. And in severe asthmatic also, it is contraindicated. See, this is what I wanted you to tell. What is the dosage? So when should you start the patient on ulipristol?
Start from the first day of our menstrual cycles.
Yes, 10 milligram or 5 milligram can be given. And how long
you should give after 12 weeks without any interruption?
Yes, without any interruption, 12 weeks you can give it. Then after that, you should stop or you can continue.
Stop
for you can continue if you want to, but usually we give a break.
Yes, generally a break of 1 month is given, and we wait till the first day of the next menstrual cycle and start continuing the tablet. So like that, how long can you give?
You can continue it even for a good few years. That's what studies shows, madam.
But generally, when we are putting it for a short-term use, maybe for 3 months or say 3 cycles, we can give.
3 cycles, yeah.
3 cycles. That is 3 months in between 2 months of gap. Okay. Now, what is the currently available incoming drug? That is the GnRH antagonist. What are the available GnRH antagonists for treatment of both fibroids and endometriosis?
Elagolix is available.
Elagolix is available.
Is it available in India, madam?
Elagolix is not available in India currently, but it is available in Amazon.
Okay.
You can get it in Amazon, and the dose is 150 to 200 milligram. And
Okay.
Relacoric combination therapy, that is with the ethinyl estradiol and norethistone combination is going to come. And the third one is the Linsagolix, like the first two are only FDA approved drugs for use in fibroid. And we have so many trials. The Elagolix trial for fibroid is Liberty trial, and Elagolix trial is Hilaris 1 and Hilaris 2 trial. Linsagolix is a Primrose trial. Okay, so then what is the advantage of GnRH antagonist over agonist? Why you prefer to use an antagonist?
Because they won't be flare up once you stop the medication.
Yes, that is the main advantage. So there was
oral, and it can be given orally. This can be given orally.
Orally, and again it is dose dependent. See, what is a bad side effect of a GnRH agonist? Changes and BMD reduction.
Hot flushes, BMD.
Is needed.
Okay. So when you are using a Elagolix combination therapy, what happens is you don't get this hot flushes are not there. Plus, you don't have much of BMD reduction because you have an estrogen and a progesterone backup there. Again, in Elagolix, the lower dose, 150 milligram OD dose, can reduce the BMD reduction and hot flushes compared to 200 milligram BID dose. So it is always the complications or the side effects of GnRH antagonists are dose dependent. So how long can be used? Maximum period of 6 months. But I think Elagolix lower dose they have tried using it even for maximum of 2 years. And they found out that then 2 years. Okay. So now moving on to case 2.
Ramani, Antilakshi here. What is your experience with mifepristone 1 for fibroid?
Madam, I am using quite a lot of mifepristone, madam, because the cost is cheaper. And the patient stops bleeding immediately. And you can continue mifepristone for, I have continued even up to 1 year, madam.
Okay. The size of the fibroid also comes down. No?
Yes, size of the fibroids also comes down, and not much of side effects. Well, the patient will say, I'm having amenorrhea. Yes. We can always counsel them saying that amenorrhea is it is how the drug, it is what is wanted. Okay, I have used quite a lot. I have used even ulipristol. In one of my cases, I will share that. Case 2 is Mrs. X, 26-year-old, married for 3 years, nulligavida, anxious to conceive, and she has a heavy menstrual bleeding for 2 years and an abdominal mass for 6 months. Okay, on examination, uterus was 22 week size with multiple fibroids ranging from 7 to 8, each ranging from 3 centimeters size to 8 centimeters. Surgery, it was planned outside. Laparoscopy was planned outside. And because it was so huge, they converted into laparotomy and proceeded with myomectomy, and ovaries and tubes were normal. And she was advised to plan pregnancy after 3 months. Okay, with this, she tried, and almost she tried for 1 year. She did not conceive and she came to me. Then on repeat ultrasound that showed multiple, again, recurrence of myoma. Uterus was 12 weeks. Myoma was not indenting the cavity. Now what to do next? She is very keen on conception. Will you go for medical management or will you go for a straight away for a fertility management?
Fertility management would be better, madam.
Better.
Fertility management with a 12-week size uterus and multiple myomas. Because myomas, we know that they have, even though they don't indent the cavity, the size matters and it has got an indirect effect upon fertility, isn't it?
Since she's young and if her ovarian reserve is good, we can go for a medical management initially, madam.
Okay. So what medical management will you prefer?
We can put her on mifepristone.
Okay. So this is what I'm telling you. Ulipristal or mifepristone can be tried. Mifepristone 25 or ulipristal 10 milligram. So then we can plan. So that is what I did. I started her on ulipristal because that time mifepristone was not available. Only ulipristal was available. And then ART was planned. So prior to doing ART, though I had confirmed that there is no submucosal extension of the myoma into the cavity, I was keen on doing a histoscopy prior to planning for ART because I wanted to know about the internal os as well as the direction for embryo transfer. And it was found to be a normal study. And controlled ovarian stimulation with ANTAC protocol was done. 6 embryos I could get it. And after 2 months, FET was done. Day 3 embryos transferred. And she conceived a single live intrauterine baby, which progressed to term. So now she has conceived through ART and now she has multiple myomas. What should you do during the antenatal period? You want to be extra careful or you want to give the same management as that of any other person?
You have to prevent her from going into preterm labor, madam. So I think I will keep her on progesterone.
Okay.
And looking at this length of the cervical length as well, if you want to put in an Arabin pessary as well, that would be safer, madam, because after this very long difficulty in getting her pregnant, you want to take the pregnancy to at least a minimum of 32 to 34 weeks.
Yes. See, how many of the panelists know about the usage of Arabin pessary for cervical prophylaxis in cervical os incompetence? How many of you know?
90% of us, all of us use it nowadays, ma'am.
Yeah, in Trichy, many of us we use, but others.
Yeah,
Dr.
we also use.
Dr. Vijaya, Dr. Chandra, have you used?
Yeah, using it of late.
Okay, good. So this particular patient was put on progestin and monitored, and she had an uneventful antenatal period, and she was on regular follow-up. Now we have to obviously plan for elective LSCS. So on opening the abdomen, the surprise was there was another huge myoma of 5 to 6 centimeters sitting on the lower uterine segment. Okay, now the next step is you need to
deliver the baby and then
go for a vertical section and deliver the baby, madam.
Go for a repeat.
Deliver the baby and remove the fibroid and do the closure if you can.
I'm saying it is sitting over right at the top of the lower uterine segment.
Then we can go for a vertical section and go for remove the baby.
No, you don't need that. You just put the incision over the fibroid, you get it and you get into the lower uterine segment.
Madam, it will take some time, no, madam, for the baby.
No, nothing happens. Nothing happens.
Just an incision.
You have to put an incision, enucleate it using a myoma screw, take it off and then get into the cavity. See, that is what I did. And baby was delivered. Because if you are going to put a upper segment section or a T-shaped incision, then it is going to cause problem in and closure, everything. And moreover, this patient, because of her previous multiple myomas that are removed by laparotomy, she had dense additions also. So I could not get into the upper segment. So necessarily I have to go through a myomectomy. See, this is what that before delivering, I think Revati madam would have done this, no madam?
Yeah.
Madam,
See, another thing is that, as Jasmine said, after all, it is only elective section, so nothing much to worry about the baby.
Yes.
Okay.
Yeah, we have also done the same thing, Ramani.
Yeah, myomectomy deliver the baby, and uterine closure
Right.
was done. So she had an uneven.
The instruction is always myomectomy during cesarean section indication. When it is on the line of incision.
Yes,
that is the teaching.
First indication. Okay, but after cesarean, completion of cesarean, we can try if cesarean myomectomy after delivery of the fetus is, again it is not contraindicated, because there are a lot of literature evidence to say that a competent surgeon with the modern use of cautery and vasopressin and so many things, we can safely go for a cesarean myomectomy. So then the next thing is, I had advised her to put for prevention of recurrence of myoma, what should you do?
Marina.
What would you do if she says that I don't want my fibroids to come back again?
Can put her on some progestin releasing IUC.
Yes, but that as usual, our friend did not turn up, and she came back after 1 year with complaints of amenorrhea. Okay, when I did an UPT, it was positive, and a nice 6 to 7 weeks fetus was floating in the uterus. So I was happy. First, she had to go through an IRT, and this one was a uneventful pregnancy, took her to term. And again, see, when I did the section, there was one submucous myoma of 3 to 4 centimeters sitting inside. So what to do?
Cesarean hysterectomy.
Madam, madam, the uterus could not be pulled out of the cavity.
Put a Marina inside, madam. Put her on Marina. Put a Marina inside during the section itself.
Yes, yes. Again, for this time, she was more cautious. She came back and had the property, LNG IUS. So discussion is, when you are doing myomectomy, what are the principles you should be careful? See, this is leave alone this for this particular patient. When you are doing a myomectomy, you
try and avoid.
You have to avoid multiple incisions.
Avoid multiple incisions. Multiple incisions.
Multiple incision, but you want to go for a tunneling incision?
Possible.
No. Madam, what is your choice, Anjalakshi madam? You don't want multiple incision, or you want to go for a tunneling incision?
Tunneling, if possible, we can do that.
Okay, but now the current thing is, if you are going to go for a tunneling incision, it will weaken the scar.
Oh, okay, okay.
So, preferably, you put an incision over the myoma, and what are the precautions you should take before to reduce the bleeding?
Vasopressin.
We can use vasopressin, madam. 20 international units.
For uterine artery ligation, uterine artery clamping, along with the infundibulopelvic ligament clamping, you can go for a myomectomy. And again, now we use cautery rather than the knife, so that all those things will reduce the bleeding. Okay. So then when this one, I think we have answered. After myomectomy, how long you should wait to plan pregnancy? Maybe 3 to 6 months.
3 to 6 months. Yeah.
Okay. Then fertility mode of fertility treatment, it depends. For this particular patient, she needed only ART, but we have been again fooled. The nature has taken over us. She has had a normal pregnancy. Then care during pregnancy, you had all mentioned that we have to be very careful regarding the not only the preterm labor, then what are the other complications? You have forgotten to mention the dreaded complication. Post yes, placenta accreta. Then malformation, fetal malposition. Fetal malposition can happen. Placenta accreta syndrome can happen. So actually, one experience I'll share with you. There was a huge post-eval myoma, which I did. Then that particular patient, she had a placenta accreta. It was coming into the period surface also. So what are you going to do in such situation? You get the consent for? Hysterectomy. So deliver the baby, in situ, you clamp and do everything. Okay. Then what weeks of gestation you will plan delivery? Will you allow for a vaginal delivery or for a definitely for a C-section?
For an elective cesarean at 34 weeks, madam.
34.
37, madam.
No, 37.
Not 34.
37 will be ideal. 37
ideal.
If you are confident about your previous scar integrity, and if it is only 1 or 2 myomas, but not like this, like huge, this multiple myomas.
Multiple, here it
Always
is.
safe to go up to 37 weeks. Otherwise, If you think that the scar dehiscence is likely to happen, maybe 34 weeks. Then I think cesarean myomectomy role we have discussed. Any patient with multiple myomas during C-section, you can go ahead boldly. Not only that cesarean myoma at a lower segment is an indication, but any sort of myoma, you can undergo cesarean, you can undertake cesarean myomectomy. Suppose what are the chances of requiring hysterectomy for this patient? Madam has already said that the patient take off the uterus and go make the patient free. But again, the chances for hysterectomy may be high in future, but during labor, during the C-section, I was not for doing hysterectomy because I could not remove the uterus from deliver the uterus from the peritoneal cavity. Okay. So now going to case 3, it was a Madam,
Ramani, from this, I understood that submucous myoma cannot be the reason for infertility.
Yes. See, generally we say submucous myoma is the cause, but here probably the myoma to begin with at the time of conception, it may be like 50% within. It could have grown. So, but
Ramani, you can explain her incision. You have put an incision,
Madam,
no?
and the her incision only, madam, incision over the myoma, you nucleate the myoma and extend the incision. That's all.
Okay, right.
But what sometimes, no, I have done, enucleate the fibroid, then put the incision.
Yes, whichever way, whichever.
As madam said, it's an elective case, no? So no botheration about the fetus. So enucleate it, then you can proceed.
Or sometimes what I have done is, if the myoma is in the lower uterine segment, and if the lower margin of the myoma is felt clearly, I have made an incision in the lower margin of the fibroid and opened the cavity, delivered the baby. Then before closure of the uterine scar, we can remove the myoma. That is also possible. Anyway. Okay. So the third case is a primigravida with a LMP of 23/1/24. UPT was positive. She was complaining of spotting PV for 2 days. Regular menstrual cycle, no family or past history, nothing was significant. And no twin conception also. It was a spontaneous conception for her. Her general condition and systemic examination was normal. And she had a mass arising from the pelvis of 20 weeks of gravid uterus. It was a firm mass. It does not look like a pregnant uterus. Because I said that her LMP was 23/1. Okay. So it is hardly 8 to 10 weeks now. But her size of the uterus was 20 weeks. So one possibility is delayed. I mean, she would have forgotten the LMP because she was having spotting on and off. Okay. Other possibility is an associated mass. So on perabdominal examination, she was having a 20 weeks gravid uterus. And in view of large size of uterus, ultrasound was done on 5/3, that is last month, which showed a 6 weeks pregnancy with fetal heart and large fundoposterior myoma of size 10 to 9 centimeters. Now, what is going to be your plan?
Is it subserous or intramural?
Fundoposterior.
Okay.
Flat, not subserous. What are you going to do? 10 to 9 centimeters myoma.
You have to continue the pregnancy.
Yes, continue
some
the pregnancy.
progestins.
Okay. So the patient was advised. So this was, you can see the huge myoma. Okay. And a small plaque here. So she was put on micronized progesterone, duphaston, as she was having bleeding also. So with the threatened abortion, now the current treatment is to give the patient dydrogesterone 40 milligram stat followed by 20 milligram BID. And then she was asked to come for a dating scan. And she had a beautiful fetal heart and the baby was growing with still the large fundoposterior myoma was also persistent. So this was the ultrasound, live ultrasound view. And you can see the beautiful baby floating inside. And you see the large myoma. So one important thing we have to see here is, you look at the placenta and the fibroid. So what is the position of the placenta, association of the placenta to the fibroid?
No, there is intervening.
See, intervening myometrium is there, but The fibroid is sitting over the placental localization. See, isn't it?
Yes.
Yeah.
So now the question is, how many of you think that the myoma is going to grow in size during the second and the third trimester?
It will grow, madam, because of the hormone.
Hormonal effect. Anybody?
And if the chances
It is not
more
mandatory to grow,
huge
madam. You can
fibroid,
wait and watch.
No, you don't have to do anything. But the one thing we need to think about is like these huge fibroids undergo red degeneration during pregnancy, and the patient comes to you with pain. That is one of the main complications.
That's
See,
rare.
like one person said it may not grow. Agreed. Because
we have to wait and watch,
we have to
madam.
wait and watch. That is the main thing. Why I posted this patient is only now 9 weeks now. I have counseled her. We will wait and see. Okay.
I think this patient is going around to all the hospitals in Trichy.
I don't know whether you had also seen her.
I've met her. I think I've met her.
Okay. So the maternal complications apart from red degeneration, if it is going to be a subserous myoma, it can undergo torsion also.
Torsion.
Or sometimes you can have bleeding from the large vessels.
Yes.
Okay. So what will be the fetal complication?
IUG or, she can go for preterm labor and
She can get
malposition.
She's only 9
little
weeks.
malpositions can be there.
Yeah, in later complications. Now currently she's nine weeks, but
Abortion.
not at the
Abortion.
You can go for
We
abortion.
don't expect any fetal complication at present.
Because
placental formation is good and it's growing.
Okay. Now, what is the role of surgical intervention in this patient during the antenatal period?
No intervention unless otherwise there is a torsion or bleeding.
Torsion, bleeding, or like how Uma said, red degeneration not manageable with medicines like antibiotics and anti-inflammatory. So surgical intervention is, so suppose you say this particular patient has got severe pain and she wants to get rid of that. So what are the precautions you will take? Will you do an antenatal myomectomy or not?
Not at all. If the vitals are stable and if she is under 24 hours monitoring, it's not needed unless otherwise there is a damage.
You cannot be sitting with the patient with the 24 hours monitoring.
That's why
Not
she's
possible.
very early in pregnancy now.
Okay. Is there a role for antenatal myomectomy? And have any one of you done antenatal myomectomies?
Yes.
Madam?
No, madam, I haven't done.
There are few studies only, but not universally it is recommended.
Okay.
No,
Madam, you have not done.
anesthesia and
Anjalakshmi, madam, have you done? Anjalakshmi, madam?
Yes, I am there.
Have you
See,
done
actually, the anesthesia and the laparoscopy has become very safe. You can't do it. So even during the first trimester, recently one case of ovarian torsion with 8 weeks pregnancy, we detorted, that is, we torsion we have corrected, and the pregnancy continued.
Yes.
Okay, in
But
the
I'm
same way.
Madam, ovarian okay, madam, fibroid. Ovarian okay,
The
fibroid.
myomectomy, no, I'm telling for
Antenatal
myomectomy
myomectomy.
only. We can do it. We can do it.
Now there are a lot of studies stating that antenatal myomectomy done between the 14 weeks and the second trimester, between 14 to 26 weeks is very safe. And I have done 2 cases of antenatal myomectomy. I tell you why. One patient came to me at 9 to 10 weeks of pregnancy with a huge myoma, larger than this, 32 week size. So I gave her the option. See, one thing is, with the 32 week size myoma itself, the pregnancy is going to continue. The pregnancy is going to be very difficult. She might land up with abortion or preterm labor. So then I told her, you can go and come back after 15 days. I will tell you what to do. After 15 days, when she came with a prolapse uterus.
So
nothing else. We have to go ahead with the myomectomy. So that was a situation which forced me to do an antenatal myomectomy. I told her, only thing is, if I am going to do a myomectomy, you will either lose the baby, like it will be an abortion.
It's going to happen anyway.
Yeah, anyway. So she gave the permission And I went ahead with an antenatal myomectomy at 16 weeks of gestation, laparotomy, and because it was about 2.4 kg myoma. And then she continued the pregnancy and 38 weeks elective section. She had a healthy baby and she came back to me for 4 years later with another pregnancy. So, and the second patient whom I did was a recurrent urinary tract infection and urinary retention because of a huge myoma in the retropubic space. So that also I had to do it after 16 to 18 weeks. I think I did a myomectomy, and that was not my patient, and she went back to her primary consultant. So for this patient, do you think that you can go for a myomectomy if she has some problems? What I have discussed in the ultrasound also I have mentioned.
So after better counseling, when 14 weeks, we can take up for myomectomy antenatally.
But here the chances of bleeding is going to be there because it is right over the placenta. Okay.
I'm not for myomectomy, madam.
After myomectomy, the pregnancy continues means there will be, you have to give continuous tocolytics. Okay? Because the chances for antenatal rupture of myoma scar is going to be there. Isn't it? So if it is this, we can use only a interseed or something. Because there are literature evidences to say after antenatal myomectomy, you can put in a this mesh, which will make the scar stronger. Okay, so that is one thing. Then is there a role for cesarean myomectomy? I think we have discussed already. So probably this particular patient, if she continues uneventfully, I might plan for a cesarean myomectomy also. And I had similarly another patient, I was planning for a cesarean myomectomy, but she delivered normally.
Oh, that's good.
That's oh, she made my job simple. Then she came back after that for a okay. So now what are the complications of cesarean myomectomy?
Bleeding.
Bleeding is the main one of the things.
Bleeding, yeah. Scar, well, the healing may not be that good because of the continuous myometrial contractions and expansion of the uterus. That may be the problem.
And due to inefficient contractions, atonic PPS can be
I have
there.
one doubt.
So
during the antenatal myomectomy, can we use a cautery? Because this electrical impulses will have any problem on the baby?
Madam, I had used it, but I used a bipolar cautery. Bipolar cautery is very safe.
Correct.
That is why with pregnancy, when we do a laparoscopic surgery, what we use only a bipolar cautery.
Okay.
Bipolar cautery is very safe. Okay. So this brings to the end of the third case. You want me to discuss the fourth case or stop with this because we are running short of time?
We'll finish this case and then.
Yeah, this is the last case. So I'll go through rapidly. A 42-year-old secondary infertility referred for myomectomy to me. She was married for 3 years. That was a remarriage. She had regular menstrual cycles, one history of miscarriage through first marriage. And on examination, her uterus was 10 to 12 week size. Repeat ultrasonogram showed posterior wall adenomyosis. It was not a myoma. And the volume of the uterus was around 200 cc. Okay, so we have to be very careful in differentiating myoma from adenomyosis. That is the place where MRI helps us. Good ultrasonographist can definitely pick up the difference between adenomyosis and myoma. Okay, so the same was confirmed through MRI, and she was referred to me after having a frozen donor oocyte embryo waiting for transfer. She was sent to me for myomectomy. Now, having picked up adenomyosis, how are we going to manage this patient? Are you going to go for an adenomyomectomy or medical management? Jasmine, you are an IVF person, no? So you tell me, you have an adenomyoma, how you are going to manage?
Madam, this patient, I will prefer to go for an adenomyomectomy, madam, because 12 week size rather than going for medical management.
Adenomyomectomy mean what are all the complications you can foresee? See, the moment you do adenomyomectomy, after 3 weeks, you 3 months, you ask her to come back, she will have the same size of adenomyoma.
The recurrence.
Recurrence is so fast.
Yeah.
And the chances of weak scar dehiscence and miscarriages and rupture is known to occur in 1 in 8. So what else? Chandra madam, what will you do?
Yeah, but it's a tricky case only. But
with 200 volume, 200 cc of
yes,
volume.
definitely we have to interfere with that.
Yes, yes.
What about GnRH?
Yes, who said Vijaya?
I mean, we could give this the triple protocol which we normally do, madam. The GnRH agonist with the letrozole and the Tnfog.
3 months.
Yes. What should be the mode of treatment? Medical or surgical? Everybody.
Medical.
I mean, majority want only medical management.
Medical management.
Then if it's going to be a medical management, what will be the choice? See, before that,
we can give Zolodex, that is GnRH agonist for 3 months, once a month. Along with it, you give letrozole 5 milligrams with Tnfog for 12 weeks, madam. The volume can be assessed later at the end of 3 months. And then without letting her have a bleed again, without a withdrawal bleed, just transfer the embryos. The volume will be definitely reduced. And I'm sure you and me, we have got quite a few pregnancies with this, isn't it?
Yes. So this particular patient, do you need to go for a hysteroscopy earlier or not?
I will do, madam.
Definitely, madam.
See, this was the cavity. So irregular. We want to know the regularity of the cavity plus the direction of the cavity, length, everything we want to know before embryo transfer. So these are an irregular cavity with the endometrial defects, and you can see the strawberry appearance. So all those things are there. Okay, so hysteroscopy I did. And then these are all various pictures of adenomyotic uteri, hysteroscopic picture. So this particular patient had GnRH antagonist, agonist, letrozole, and dynages. There are studies, generally they will add along with letrozole, they add norethisterone for an add-back therapy. I prefer going in for an dynages. The reason is it will act at a different place in adenomyosis. GnRH will suppress at the central level, letrozole at both the aromatase inhibitor, and then dynages modulate the tumor necrosis alpha, uterine natural killer cell activity, and all the other parts of the abnormalities will be taken care. Okay, so this particular patient, I think I gave her, there are again studies to show that aromatase inhibitors along with GnRH will reduce the volume very rapidly regarding dynages also. And then like how Uma said, we prepared her for FET, ethereal estradiol 2 milligram twice daily. And when her ER was 9 millimeter, it was a beautiful trilaminar endometrium with a good vascularity. Since she had blast, I gave her 5 doses of sustain and then transferred with a high luteal support. I sent the patient back to my referring doctor, telling her to transfer the blast, and then she became positive. And fortunately and unfortunately, it was a tissue conception. See, one thing you must understand in adenomyosis is always do not go for more than a single blast or 2 day 3 embryos. Because multiple pregnancy in adenomyosis, the complication rate is going to be high. Okay. So this lady had an uneven full antenatal period and she delivered by elective section. I think we will finish with this. We have crossed the time by 10 or 15 minutes. And we have another program at Trichy after 7.
Ramani, I have a patient, we have come for infertility. She has got a posterior intramural fibroid.
Okay.
So what will be your advice to
size of the fibroid?
3 to 5, 3 and 5.
2 myomas.
No, single 2 dimensions, 3 centimeters. Yeah.
Is it involving the cavity, indenting the cavity?
No, it is not indenting the cavity.
Means we can have a normal trial. FET can be done. But if your first FET fails, I think it is better to go for a myomectomy before going for the second. What do you say, Uma?
Sorry, madam. I didn't get you.
No, she said, Jasmine, you are listening.
Yes.
But do you want to go for a myomectomy before going for a second transfer?
Yeah, madam, definitely, because she has already one loss of pregnancy out of the blast. And we don't want to wastage one more blast transfer. So I would like prefer to go for a lap myomectomy for her.
Okay.
Ramani, congrats. It was a very nice panel, Ramani.
Thank you, madam. Thank you, madam.
Very much. We learned a
Nice
lot.
panel, nice discussion with the panelists also.
Thank you,
Nice.
madam. Thank you.
Thank you.
Thank you.
All
Thank you.
3 of the cases are my recent cases. Only one was the past case. Okay.
I just want to give the take home message for the practitioners, because recently I had 2 patients referred because for second opinion for hysterectomy. Post menopause and menopause 4 years ago, multiple fibroids, each 1 centimeter only. They have advised hysterectomy. Asymptomatic.
No need.
Okay, that is it. That is what I am telling. Practitioners should know all these things. They should not go hurry for hysterectomy. Another patient, 16 weeks pregnancy with the fibroid red degeneration, they have advised termination. So these are all the wrong things being done. So we have to tell them.
Okay.
And there is a question in chat box. Is vasopressin used for myomectomy during the antenatal period?
No, we should not use vasopressin during antenatal period. No. See,
Madam,
what
about the epinephrine and
see, all those things are vasopressin, epinephrine, all those things are vasoconstrictors. You cannot use it. But if at all you want to prevent bleeding during antenatal period, what you can do is you can take a bursting suture at the base of around the myoma. Okay, then you use a bipolar cautery. Then you can use a bulldog clamp to clamp the uterine artery and temporarily occlude the infant pelvic. Then go ahead. Be very fast. Your action should be very fast.
Thank you so much, ma'am. It's in the chat box.
Radhika ma'am, shall we launch second question now?
Yes.
Yes.
Second question answer I have given in my presentation itself.
Liberty trial. Okay.
Actually, you can put the questions, no?
She has shared Liberty trial.
Yes.
Liberty trial is for fibroid use with the drug of elagolix or linsagolix. Don't tell you, they let them answer.
Sakiti, you didn't post it.
Yes, posted Sampath. Yes, posted. On the screen.
Last 5 seconds. Time up.
Sampath results எப்ப உடனே சொல்லிடுவீங்களா? I have got a
இப்ப ஒரு 5 நிமிஷத்துல சொல்லிடுவா.
Okay, ஒரு glucometer price for both.
Okay, first correct answer. அதுக்குதான்.
Correct answer glucometer price.
முடிக்கிறதுக்குள்ள சொல்லிடுவா.
Second price will be this one, pulse oximeter. Okay.
யார் பிரைஸ் வின்னரோ நீங்க அட்ரஸ் இதுல போடணும், அப்பதான் வந்து கிடைக்கும்.
இதுல போட்டுருவோம்.
In the meantime, Sagiti, how many minutes it will take?
5 minutes, ma'am.
5 minutes.
Please give your address.
என்னவோ போட்டிருக்காங்க ராதிகா தோரி. நம்ம இது vasopressin used. அது ஆன்சர் பண்ணிட்டீங்களா மேடம்? ரமணி மேடம்?
பண்ணியாச்சு
மேடம்.
Good evening. Meenakshi, I will come around 7:15 or before 7:30. I will. Okay.
சரியா, உங்களுக்கு இப்ப இது மட்டும் தான் போடுறீங்க.
இருக்காங்க. ஆரம்பிக்கும் போது 84 58 தான் இருக்காங்க.
நைட் வந்து 18 போடுறீங்கல்ல, அது 22 போடுங்க.
Sakiti, in your phone number இருக்குமான்னு தெரியல. Prize winners, please give your address so that prizes in prize யாருக்குனே சொல்லாம அட்ரஸ் சொல்லுவீங்கன்னா
இல்ல முன்னாடியே காஷியஸா ரெடி பண்ணி வச்சுக்கிறேன், அவ்வளவுதான்.
நீ வாட் ஆஃப் டைம் சொல்லு ராதிகா.
Very ma'am, thank you so much for giving me this opportunity, Sampath ma'am and Ramani ma'am, and it was a wonderful session. We thank the chief guest, Dr. Parul Kotwal sir and Neeraja Bhatla ma'am. I thank the judges, Dr. Revati ma'am and Dr. Karthika Prabhu ma'am for wonderfully chairing the session. I thank the doctors who presented, Dr. Swati and Dr. Pratibha. It was a wonderful, actually, a revision for all of us regarding the fibroid origin and management, investigations, and all the details. And the panel discussion was the top on all the whole session. Thank you very much, Ramani ma'am, and all the madams, Dr. Uma madam, Chandra ma'am, and Mahalakshmi ma'am, and Jasmine ma'am, and Dr. Vijaya ma'am. It was really a wonderful session. I thank Dr. Chitra ma'am for a wonderful presentation. And she covered all the aspects of the management, medical, surgical, and other modes of management of the fibroid, which is a very common day-to-day, the condition which we all meet every day. So thank you so much. And I thank Sahiti for coordinating and leading this program. Thank you so much for our online support.
Results are out, ma'am.
Yes, Shagiti, you can put the first question and the second. Thank you, Shield Radhika.
Thank you, ma'am.
Yes, first question, Shweta Dariwal from Chennai.
Okay.
Madam, Ramani madam phone number, இத வந்து நான் screenshot எடுத்து தரேன் உங்களுக்கு.
நானே எடுத்துறேன்.
Second question is Soundarya, both from Chennai.
Good. Congratulations.
Spread பண்ணுங்க மெசேஜ்னு சொல்றேன். முதல்ல ஒரு
Congratulations.
Yes, madam. Congratulations, Shweta and Soundarya. என்ன சொன்னீங்க Ramani madam? Glucometer and
one pulse oximeter.
Yes, it will reach you, Dr. Shweta and Dr. Soundarya. Thank you. Thank you, sir.
Thank you, ma'am. Thank you.
ஒரு என்னோட suggestion வந்து shall we have a pre-test and post-test மாதிரி இருங்க உங்களோட இத மயிலாப்பூர்ல அவங்க போட்டுட்டாங்க. ஸ்வேதா ஐயோ முன்னாடி போங்களே அந்த chat boxல போட்டுருக்காங்க.
Shweta Sampath Nursing Home, Shweta. Okay, madam. Yes, Sampath Nursing Home, Natyapan Street, Mylapore. Okay. Shweta Dariwal. இன்னொன்னு சௌந்தர்யாவா போட்டுண்டா. Congrats, Shweta.
Thank you, ma'am.
Thank you, ma'am. Thank you, ma'am.
Thank you, everybody.
Thank you. Bye. Bye.
Ramani, Sampath, Revati madam, Anjalakshmi madam.
Madam, thank you so much to all the participants, panelists, and the Revati madam, Anjalakshmi madam, Sampath madam, and everybody. Next time,
bye.
இது போடலாம் Sampath.